diagnosis of these disorders. Its management includes the management of the renal pathology as well. Now, there are some general slides which I'll be dealing with whenever we are thinking of a monogenic etiology, and the workflow or the decisions remain the same. So if you have a specific phenotype of a known disease where the gene is known, or there are some specific hotspot mutations which are causing that particular disease, then you can have a targeted testing, which may be in the form of some specific test like ARMS or MLPA or Sanger sequencing of a specific exon. Or you may sequence the whole gene if it's a small gene. But in situations where the genes are large, NGS-based testing turns out to be cheaper. So here the example would be something like tuberous sclerosis, where you know that renal involvement may be there and there are two genes which are big genes. Here NGS-based testing may be more useful rather than doing Sanger sequencing of the whole gene. The other scenario could be when you have an overlapping phenotype of suspected group of disorders, and there are a number of genes which are known genes which are positive. So here we call this as a panel, and this panel-based testing may include in nephrology testing a panel for, say, steroid-resistant nephrotic syndrome or tubulopathies and so on and so forth. Then you may have a situation where you are suspecting a single gene disorder based on the phenotype, and you have not reached to a diagnosis despite the tests which you have done. And in this situation, NGS-based tests, which include clinical exome sequencing and whole exome sequencing, are useful. When we do clinical exome or whole exome sequencing, trios are preferred, which means that the affected individual and the parents, because the yield becomes better in this situation. If this also does not yield to any conclusion, then we go on and do whole genome sequencing, which is most of the time restricted to research, but it is coming into clinical practice, and maybe in near future it may be used more often. And after this, if you get some conclusions, you interpret the test properly, do counseling and intervention as required. So this is just a diagram to show you what is whole exome and whole genome sequencing. And as you understand, exome constitute about 1% of the genome, and most of the variations lie in these exons, which are positive for monogenic disorders. So when we are talking of whole exome sequencing, we are only sequencing the exons, whereas if we are talking of whole genome sequencing, both introns and exons are being sequenced. So these are very high throughput technique, and they parallelly sequence multiple genes. And because of this, the cost has dramatically come down. So if we compare the clinical exome, the whole exome and the whole genome, classically clinical exome would cover 5,000 to 6,000 clinically relevant genes, and this would vary from lab to lab, whereas whole exome sequencing should theoretically include 20,000 genes which are reported to be disease causing. And then you have the whole genome sequencing, which cover the coding and non-coding region of the genome. So clinical exome, restricted number of genes, and you cannot detect novel genes, whereas whole exome, because it covers all the genes, reported genes, it can detect novel variations also. And obviously both these cannot detect the variations outside the exonic region. Whole genome would cover everything, but the interpretations are complicated because huge data is generated and they are currently quite expensive. The use presently is clinical for clinical exome, even for whole exome. The whole exome is being used for research purposes as well. Whole genome, as I said earlier, used more in research setting, but it is coming into clinical practice very rapidly. Importantly, the copy number variations with the traditional pipelines of bioinformatics are not detected in clinical exome and whole exome, whereas they can be detected by whole genome. But now with the improved bioinformatics and the pipelines which have been modified, even copy number variations can be detected by whole exome and clinical exome sequencing. Now, when we talk of the yield which is there by NGS, because I talked of trios versus solo sequencing. So if you are doing trio-based sequencing whole genome and trio-based sequencing whole exome, the yields are almost similar, though some recent studies indicate that probably for genome it would be higher. So they are almost comparable, 40–45%, whereas proband only is about 28–30%. And if you have a channel-based testing, that it would panel-based testing, then it would depend on the panel which you have selected and how tightly you have recognized the phenotype. Now, just to explain again the concept of targeted whole exome and whole genome sequencing, and as you see here, targeted is a panel. Clinical exome is somewhere between the targeted panel and the whole exome. Whole exome will cover all known 20,000 genes. Here they will be including the morbid genes which are disease causing, and whole genome will cover everything. So it is important to understand what do we mean by a read depth versus a gene coverage. So gene coverage means that what percentage of the genes of interest are covered when we are doing the NGS-based testing. So obviously, when we are doing a targeted testing or a clinical exome and the number of genes is small, the coverage is likely to be more as compared to whole exome and whole genome sequencing. So here, more proportion of genes of interest may be covered. The read depth means that how many times that particular region has been sequenced, because as you increase the number of times the region has been sequenced, the specificity increases. In usual clinical practice, nowadays we are accepting about 30x to 50x, and at times you will see that they have covered it 100x or something. Now, whenever we are offering a test, I think it is important that we think that is this the right test for the disorder? Then we choose accordingly a targeted versus a whole exome or a clinical exome. We have to have a very good information on the phenotype because that is important for interpretation. Are all the required and the genes which are known are included in the panel? Depth and coverage, as I just said, yield, what is a likely yield with this particular test, the cost and the turnaround time, and the problems in the interpretation have to be explained to the family. So when you get the results, after the evaluation, which is very extensive because they get a large number of variants which are to be filtered at various levels before we can come down to the causative variant, which may not be reached, removing the variations which are found in the normal population, and then you may or you may not reach to a conclusion. So the results would show different things. It could be a single likely causative variant, pathogenic or likely pathogenic, or multiple candidate variants, again pathogenic or likely pathogenic. And importantly, the problem is there when you get the variations of unknown significance, which you are not able to interpret, because the disease phenotype may be correlating, but these are not classified as pathogenic or likely pathogenic. This classification is based on the ACMG guidelines. You may get a benign or likely benign or no possible variant. Now, it is important that from time to time we keep on reviewing the status of the variations of unknown significance in the databases because the status may change. The variation, which was variation of unknown significance, may change to a pathogenic or a likely pathogenic, and reanalysis of the raw data at times gives results which may not have been picked earlier, and this is being practiced by many units, including ours. And families should be counseled about all these possibilities before offering the test. So counseling, I have already touched upon: cost, yield, turnaround time, problems in interpretation, incidental findings, secondary findings, which may pop up and we were not thinking about it, and the family should be told about that do they want to the results also regarding these, the relationship, and then at times we may require testing of the additional family members, which might be difficult at times. Whole exome sequencing has limitations because positive variants in the non-coding regulatory regions may not be identified. Large deletions, duplications, rearrangements are not identified. As I said, the whole gene may not be covered, and the public databases which are incomplete often and may not be updated. We may not get the data when we try to interpret these variations, and they may be population variations. So in Indian population, the variation databases should be there, and there have been efforts, and we have India-specific databases which may be used for interpretation of these results. So the overall workflow of NGS begins with the clinic and ends in the clinic. And in between, there's a lot of interaction between the lab and the clinicians to reach to conclusions. So it cannot be done in isolation that a clinician orders a test and the lab gives you the results. We have to give them important information and they have to interact with us to reach to conclusions. And as I have already told, reanalysis and reclassification has to be kept in mind. Now coming on to some renal specific literature. So here, this is a publication from NEJM, large cohort of patients, more than 3,000, where they tried to find out the yield of exome sequencing for kidney diseases, and various groups of diseases were included in this particular cohort. And the conclusions which they found was that the yield was about 10%, which were specific monogenic disorders like cystic renal diseases also. But importantly, about 17% of nephropathies of unknown etaology, they could find a cause. And out of the yield which they found in about 10% of cases, about 1.6%, there were results which were medically actionable. And this figure shows you from the same study that various genes have been implicated in different types of kidney diseases. And you can see for congenital and cystic diseases, multiple genes. You can see these red bars, and then for glomerular diseases also. But important to note here that diseases of unknown origin also could be detected by identifying variations in multiple genes. And here lies the importance of doing more expanded or say whole exome sequencing in scenarios where the phenotype is not very classical. Now, this is another study where they tried to compare the panel-based testing with the whole exome sequencing. So about 300 patients they included, and initially they used panels for various disorders, and here the yield was about 13%. Later on, they went back to the data and checked the whole exome data on the same patients, and the yield improved to 20 to 30%. So what they did initially was they had different panels for different groups of disorders. Like here you have hemolytic uremic syndrome, thrombotic microangiopathy, C3-related glomerulopathy, LPOT, cystic disease, and nephrotic syndrome. These are the genes which they included. And then the yield was about 13% overall. But when they went back and searched the whole exome data, they found that more genes and variations were implicated. And you can see the yield was significant in atypical HUS, to some extent in nephrotic syndrome also, and in other diseases as well. So here lies the importance of doing more expanded testing using whole exome sequencing in certain renal disorders. So this slide just shows you the evolution of genetic diagnosis in steroid-resistant nephrotic syndrome. So in the beginning, few genes were being tested and the yield was low. And as we are progressing towards, say, whole exome sequencing, the yield becomes higher. From case to case, from patient to patient, we really need to think and consider that which would be the best test, as I discussed earlier. So about 24 to 30% of cases of steroid-resistant nephrotic syndrome have a genetic basis. So what are the benefits of diagnosing an inherited kidney disease? So it may lead to an end to a diagnostic odyssey for many patients, because these patients may be running from one place to the other to get a diagnosis. And it may also have clear repercussions for prognosis, management, and sometimes even treatment. So these are some of the examples. Like if you have FSGS of genetic origin, the likelihood of recurrence in transplant is almost non-existent. In proteinuria kidney diseases, corticosteroids and immunosuppression may not be useful. So these patients may not be given these drugs. And if you're thinking in terms of donors for transplantation, and if the disease is of genetic etiology, obviously the donors have to be tested for that particular genetic disorder before being considered as a donor. And then genetic testing may avoid an invasive procedure like kidney biopsy. And if you have a specific phenotype where there's a significant proportion of cases of genetic etiology, we may directly go in for a non-invasive blood sampling, non-invasive test, which is just a blood sampling for genetic tests, and we may get an answer. And in some situations, kidney biopsies may be avoided. And importantly for all of us, and particularly for clinical geneticists like us, genetic counseling, pre-symptomatic testing, and prenatal diagnosis, or even pre-implantation genetic diagnosis can be offered to these families because of the risk of recurrence which these diseases have, and the chronic nature, disabling nature of these diseases, and many of these may not be having any cure if the families are interested in taking up prenatal testing for prevention of birth of affected babies. So I would end here, and from now on, Dr. Aditi will be taking case scenarios. Good morning. At the outset, I would like to thank the organizers for giving me this opportunity to participate in this interesting session. The first session on genetics and kidney disease deals with steroid.
At the outset, I would like to thank the organizers for giving me this opportunity to participate in this symposium. Thank you, Dr. Madhulika, for illustrating very nicely the utility of genetic testing in diagnosis of kidney diseases. We now proceed to examining some cases how children's proteinuria and hematuria had utility of genetic testing in diagnosing their condition and what impact it had on their management. Our first case is that of a 6-month-old boy infant who has been symptomatic since 15 days of life with what is suggestive of typical nephrotic state. However, he has been currently admitted with us with a severe pneumonia and severe acute kidney injury requiring hemodialysis and nasal prongs, high flow nasal cannula. If we look at the evaluation that have been performed since onset of disease in this child at various different private hospitals, we find that the renal function tests were essentially normal till presentation to our hospital with severe acute kidney injury. The electrolytes were fairly all right. Serum albumins had always been low. There was nephrotic range proteinuria with a bland urinary sediment with high urine protein creatinine ratio and no evidence of an intrauterine infection which could have been responsible for his congenital nephrotic syndrome. He was born in a non-consanguineous family and there was no family history of similar illness. Overall, this is what is congenital nephrotic syndrome, onset of nephrotic state at less than 3 months of age. And whenever this is the circumstance, one must always think monogenic for reasons that we will see through data presented later. Overall, conditions presenting as congenital nephrotic syndrome are more or less caused by inherited defects in proteins which have been encoded for by genes which are shown on this slide. And majority of these are in the podocyte slit diaphragm or the actin cytoskeleton or interactions of the podocytes with the basement membrane or various transcription factors. The genes encircled in red are the ones that are most commonly implicated. And the table here illustrates in blue these most important genes. Whether in Finnish or in non-Finnish forms of congenital nephrotic syndrome, it is NPHS1 mutations encoding for the protein nephrin in the slit diaphragm, which are responsible for the majority of cases. Other genes that have been implicated have been the slit diaphragm podosin protein encoded for by the NPHS2, the transcription factor WT1, LAMP2 and PLC1, which are located in the basement membrane and intracellularly respectively. LAMP2 and PLC1 seem to have specific phenotype and or histology respectively, whereas WT1 may or may not have a specific phenotype, and NPHS1 and 2 typically do not have much extrarenal features. If we look at data from across the studies that have been published in this regard, based on the technique of genetic screening, the yield of genetic testing has varied. It has also varied by ethnicity. For example, data from Japan and China do not indicate a high prevalence of genetic abnormalities when looking at children with congenital nephrotic syndrome. This might, however, because of the fact that they screen for a few genes only. When we look at approaches utilizing next-gen sequencing, we find a high yield of genetic diagnosis in majority of cases, with NPHS1 and NPHS2 predominating as the cause. So therefore, we also looked at the etiology of congenital nephrotic syndrome in 41 patients sampled from across the country as part of a NephQuest consortium, which was a cross-sectional study supported by the DBT over 2016 to 2022. And we found that the majority of patients did carry a pathogenic or likely pathogenic variation. In 85% of cases, we could find a monogenic cause, which was ascribed chiefly to NPHS1 changes. Now, we can see that 3/4 of the cases of congenital nephrotic syndrome were really caused by NPHS1 variants. And if you were to look closely, only 3 particular variants were responsible for half the cases of congenital nephrotic syndrome in our cohort, which was a very important finding, because if we were to design just say PCRs for these 3 variations, we would be able to diagnose congenital nephrotic syndrome correctly in the majority of patients. You can also see that the NPHS1 variations were really distributed all over the nephrin gene, and there were no precise hotspots. It is important also to recognize the fact that 2 of these variations, the first 2 ones, are really founder mutations in our population. That is, these mutations are not found outside of the South Asian population. Going forward, we know that congenital nephrotic syndrome is almost a uniformly fatal disease if we do not have access to kidney transplantation. Majority of patients would progress at a median of 2 years of age to kidney failure. And even before 2 years of age, majority of them, if not treated appropriately, would succumb either to Anasaka-related complication or a severe infection. And therefore, given the fact that majority of conditions are autosomal recessive in nature, inherited in that manner, prenatal testing and counseling can be offered if a genetic diagnosis can be made, and a genetic diagnosis is likely in 70 to 80% of cases. Therefore, current recommendations on congenital nephrotic syndrome management and evaluation rely very heavily on testing for a gene panel, using a comprehensive genetic screening strategy such as next-gen sequencing for all podocyte-related gene as a first-line diagnostic measure. You can see, therefore, that kidney biopsy has been relegated to a very distant second in this approach. So we rely very heavily on genetic screening and not so much on kidney biopsy when managing patients with congenital nephrotic syndrome. And if you do not have access to sequencing the panel of genes by next-gen sequencing, at least screen the NPHS gene carefully by Sanger sequencing, failing which, if you don't find any problems there, go on to sequence other genes such as NPHS2, WT1, PLC, and LAMP2, because these are the most important genes causing congenital nephrotic syndrome. Kidney biopsy is an invasive procedure and is considered only in patients in whom a genetic diagnosis cannot therefore be established. We come now to our second case, which is that of a 10-month-old girl who presented to us with puffiness of face since 7.5 months of age, with typical features of nephrotic syndrome on evaluation elsewhere, and had been managed as a nephrotic syndrome patient, initiated on prednisolone therapy, and given that there was no response to 4 weeks of corticosteroid, she was labeled as initial steroid resistance and referred to us. The referring physician had thought that we would be starting a therapy with calcineurin inhibitor, and we would also be performing a kidney biopsy. Now, why would we be doing that? We know that majority of cases of nephrotic syndrome tend to be steroid sensitive in nature, and they respond to corticosteroid. The 10 to 15% cases that usually do not respond at onset of disease, termed initial steroid resistance. A small proportion do not respond later in a disease course, late steroid resistance. Majority of patients with steroid sensitive disease and late steroid resistance, and also a major fraction of initial steroid resistance, would be caused by what is known as a circulating factor. The identity of this circulating factor is still not understood. We understand that it is probably an immune-mediated factor because it goes and acts on the glomerulopodocytes putatively in a manner such that it affects their integrity and causes them to become effaced. And whether this is a cytokine or another circulating factor, we do not understand, but probably it is suppressed when you give immunosuppression, and therefore the podocytes become erect again and they have their slit diaphragms intact again, and proteinuria abates. On the other hand, a small proportion of cases, typically those who never responded even to steroids, initial steroid resistance that is, might be caused by mutations in key podocyte genes. And these mutations would affect the actin cytoskeleton or slit diaphragm or the basement membrane interactions in such a way that proteinuria happens. And this obviously would not respond to immunosuppression. It is important to recognize this fraction. Now, how do we know who this patient is who has monogenic cause and requires genetic testing? Overall, an early onset of disease perhaps suggests steroid resistance more than steroid sensitive disease. This is unpublished data from our own NEFQuest consortium longitudinal disease follow-ups of almost 1,500 patients, wherein we find that patients with steroid resistance are tending to be 10 months younger than those with steroid sensitive disease. Even within the steroid resistance, it is found based on data from large data sets of the PODONET registry, the Hildebrandt's work at USA, and the RADAR registry, that the younger the patient, the prevalence of monogenic etiology is the higher. So these graphs and these bar diagrams indicate the same result, that the proportion with monogenic cause is the highest in the youngest. So we come back to our patient. We ordered next-gen sequencing. We did not perform a biopsy because she had onset of disease at 7.5 months. We felt that monogenic disease was far more likely. We need to figure out what's going on with her. To give her the benefit of immunosuppression, we did start her on cyclosporin. We started an ACE inhibitor for non-immunosuppressive reduction of proteinuria. And we asked for review back with the genetics report in 4 weeks. The report did show a WT1 change, which was a likely pathogenic change previously reported in patients with steroid-resistant nephrotic syndrome and also associated with Wilms tumor. So we therefore advised parents to withdraw immunosuppression, counsel them about the risks of kidney failure as also the risks of Wilms tumor, and ask them to follow up quickly with an ultrasound and also periodic ultrasounds in the next 2 years of follow-up. However, because of the pandemic and ensuing lockdown, an ultrasound could not be performed until much later when the child was fairly poorly symptomatic with a large Wilms tumor. And despite all forms of salvage, including chemotherapy, radiotherapy, and surgery, parents elected for a palliative care plan, and the child succumbed at home. The same identical mutation, but a different child. This child had presented to a pediatric surgeon at 7 months of age, where he was operated for hypospadias and cryptorchidism. An abdominal lump was noticed 3 months later and was confirmed to be that of a Wilms tumor by ultrasound as well as histology, which showed small round cells. He was managed with nephrectomy and post-op chemotherapy, but he developed post-operative septicemia, developed severe AKI. The other kidney, which was then showing nephrotic range proteinuria, shut down completely. He was then transferred to our center for hemodialysis. We sent out genetics, and the genetics confirmed the same WT1 change as in the other child who had presented to us with sporadic steroid resistance and had later developed WT1, Wilms tumor. Now, another third patient who had presented similarly, similar to any sporadic steroid-resistant nephrotic syndrome to us, but did not respond to immunosuppression, had been seen at our center since 8 years of age. She had not responded to IV cyclophosphamide, which was given as the first-line immunosuppression for steroid resistance elsewhere. Then she came to us. We tried cyclosporin. She responded nicely to cyclosporin. She did well for a couple of years with partial remission, that is lack of edema, improvement in serum albumin to the non-nephrotic range, proteinuria decline to the non-nephrotic range, and she did well for 2 years. But then subsequently, she had non-response. We tried out other medications which did not make an impact, and slowly she progressed to advanced kidney disease, and she was planned for a preemptive transplantation when she returned for review again. At that time, we were concerned about her delayed puberty, as was the child herself, that she is 14 and has no secondary sexual characteristics at all. The ultrasound showed streak gonads. Otherwise, there was absolutely nothing in the family history or in the morphology of the child or the scholastic performance to suggest anything different. Very surprisingly, she had a male karyotype. And this girl had been reared as a girl all along. Parents chose not to disclose her true gender to her. At that time, Sonika Sharma was a PhD student with Dr. Madhulika, and this is a story 12 years old. At that time, she was performing her thesis on genetics of nephrotic syndrome using a technique of RFLP followed by Sanger sequencing of NPHS1, NPHS2, and NPHS and WT1. And she found and confirmed for us that this child has a WT1 change, which is a pathogenic change in the splice site area of the exon 8 and intron 9. So the spectrum of WT1 glomerulopathies as depicted by these 3 cases varies really markedly between 3 clear distinct phenotypes, one of a Dennis-Trash syndrome, another of a Frazier syndrome, and the other of sporadic FSGS, which is at risk of Wilms tumor as well. Now, this girl, the boy had Dennis-Strass syndrome, the older girl had Frazier syndrome. You can see the typical features outlined here on these two slides, and you can see that the kids with Dennis-Strass syndrome present early with nephrotic syndrome, rapid progression to kidney failure, and they are at very high risk of Wilms tumor. They might have complete or partial dysgenesis of gonads and diffuse close to within our population monogenic, because almost a third of cases of adulthood onset nephrotic syndrome, almost 10 to 15% of cases of adulthood onset sporadic steroid nephrotic syndrome is now shown to be monogenic in nature. And samples Dr. Hildebrand if they had a setting in which they felt that the child has a genetic cause. For example, we had sent the family samples to Dr. Hildebrand's unit because the patients were not responding and they were of a familial disease wherein we thought it is a genetic cause. We would not have sent the samples of all other children. Likewise would be true for other clinicians all across the globe. Even so, we do understand that at least it's not more than 30% given this kind of circumstance. The most common genes implicated have been NPHS2 and NPHS1, depending on the age of onset, WT1, and other such genes. What about disease in adults? Can it be monogenic? Yes, indeed, it can be monogenic because almost a third of cases of adulthood onset nephrotic syndrome, almost 10 to 15% of cases of adulthood onset sporadic steroid nephrotic syndrome is now shown to be monogenic in nature. And almost half of these cases are actually caused by variations in COL4A3, A4, or A5 genes. There is significant amount of geographic variation in the prevalence of monogenic disease because majority of these conditions are autosomal recessive, and you know that the rates of consanguinity are very variable depending on the ethnic background of the population. There are very few reports, however, from Asia and Africa for us to be able to conclude whether the rates of monogenic disease are similar within our populations as they are in Caucasian populations. And in one report from Southeast Asia, that is the Dragon Registry, we find only 14% of cases being monogenic in etiology, whereas in Japan, they found 30% of cases. If you were to look at the genes more closely, in Japan, they found WT1 to be the most important cause. In China, they found ADCK4 to be very important. And in the Dragon Registry, they found COL4A5 to be very important. Where are we in India? When we look at our own results of the NephQuest consortium efforts through the DBT funded project, out of 268 patients who we tested, which were all initial steroid resistance, we found variations of important nature only in 16% of cases. The majority of these variations were in conventional genes, though, that is the NPHS2 and WT1. But COL4A5 was also a very, very important cause of steroid resistance in our population. The risk factors of monogenic disease were fairly similar to that has been reported elsewhere, that is familial disease, infantile age at onset, patients with an extrarenal phenotype, non-response, and progressive kidney disease were at more risk of having a monogenic cause than were patients with sporadic steroid resistance. And obviously, this slide sort of summarizes what Dr. Madhulika has already told us. Why worry about a monogenic cause? Because we have benefits from a definite genetic diagnosis. Not only do we avoid an invasive kidney biopsy like in the congenital nephrotic syndrome kid, we also avoid potentially toxic immunosuppression. and we might be able to detect certain treatable causes. We would be able to counsel the families better so that they can prepare better for the future ahead of them. Then we could offer pre-transplantation counseling and donor screening in an appropriate manner. Because say, for example, the mom of a COL4A5 variant boy who progresses to kidney failure should not be donating her kidney to her child because she herself is at some risk of kidney failure in the future. Obviously, it offers you the option of prenatal and pre-implantation testing as well as sibling testing if required. So who should we test for a monogenic disease basis? It is quite obvious now that it is only the patients with initial steroid resistance who require testing, if at all. However, should all patients with initial steroid resistance be tested? Now, herein the opinion varies. Where access is there to next-gen sequencing, Western experts would advise, please go ahead and do genetic screening for all patients with initial steroid resistance. Where access is limited, they would suggest that probably confine yourself to testing definitely those populations in which the risk of steroid resistance being monogenic is the highest. And these populations we've discussed already: infantile onset, having a diffuse mesangial sclerosis, which is known to be associated with certain mutations, and certain ethnicities. Overall, the IPNA guidelines, which are based on a lot of evidence from Europe and America, are supportive of a method of testing in which you test all patients with initial steroid resistance for a genetic cause. Now, we know that access to not just genetic testing is limited in our country, the cost is usually unaffordable, and very importantly, geneticists are few and far in between, such that we do not have access to appropriate interpretation of these variants, nor access to appropriate genetic counseling about them. So we therefore recommend a more confined strategy of testing only patients who are at high risk of having a monogenic disease, and the risk groups are defined here in the box in blue. And we suggest that when we test, we should use a next-gen sequencing panel comprising of a big panel of genes of all the podocytopathy related genes. If you already have a known cause in another index member, or if you already have it in the index patient, you're screening the sibling or the donor or a fetus, then obviously you'll go for Sanger sequencing. And once you found a genetic cause, you would withdraw immunosuppression, you would counsel the family, you would prepare for transplantation, and be aware that there is a low risk of recurrence. So we change tacks now and move to another gear of testing of patients, wherein you have a very young boy who was incidentally detected to have some microscopic hematuria and small amount of proteinuria when evaluated for fever. Unfortunately, these findings really persisted when the parents looked at subsequent urine analysis because they were concerned about these findings. They were very alarmed and they came to us. We kept evaluating for the same abnormality and we found that this is persisting, proteinuria as well as hematuria. Now, what comes to your mind? What comes to mind is two sets of conditions. Given the age of the child, we are unlikely to be dealing with an IgA nephropathy or a glomerulonephritis, inflammatory pathologies which typically affect elder children and adults. We are more likely to be dealing with an inherited glomerular basement membrane or some similar defect which is causing hematuria and proteinuria. Now, the tests to consider would be a kidney biopsy, including electron microscopy, and genetic testing. Given the age of the child and the yield of genetic testing being more useful rather than a kidney biopsy, which will not give a definite diagnosis in an inherited nephropathy, we went ahead with next-gen sequencing. Unfortunately for the boy, we found a COL4A5 pathogenic change, which was very alarming for the family to know about. However, the child has been started on ACE inhibition and continues to be followed up with us. Alport syndrome, we've just now discussed, therefore, as being one of diverse phenotypes. It is the most common inherited hematuric nephropathy. There could be asymptomatic persistent microscopic hematuria, like in this young boy who has now been detected to have the disease and will be followed up carefully all through his childhood and adulthood. To insidious onset and progressive kidney failure, to being a phenocopy of steroid-resistant nephrotic syndrome, as I just described. Obviously, the alterations can be in COL4 A3, 4, or 5 chains, A5 chains being most common. An alteration of developmental switch causes problems not just in the kidney, but also in the cochlea and in the eyes. And based on the underlying genotype, the phenotype would vary. The males with X-linked Alport and the autosomal recessive patients with Alport syndrome are the most severely affected, with early onset problems with high rate of progression to kidney failure at an earlier age than are patients with autosomal dominant disease and females with Alport syndrome. Recognizing the fact that the rates of progression of kidney failure are very much there, although lower in females with Alport uh, Col4A5 as well as in autosomal dominant Alport. The nomenclature has changed, and we now move away from calling them as benign conditions, and we call them now as Alport syndrome, regardless of the pattern of inheritance and the sex. The genetic basis of disease can be picked up by looking at classifying them by ACMG criteria. Most commonly, you would see small changes, not very large changes, but deletions and insertions are a described mechanism of disease, especially in Col4A5 changes. And therefore, if you don't find a problem on next-gen sequencing, it is recommended that an MLPA or a long-range PCR or quantitative PCR be performed to examine for such deletions or insertions. There are certain mutational hotspots in the protein. There are certain variations that are known to be incidental findings and therefore not of significance. There are also certain variants that are known to cause a hypomorphic phenotype. The type of variant really determines the severity of disease in X-linked Alport. So large rearrangements and frame shift truncating changes are known to have a high probability of kidney failure, and the splice site ones intermediate probability, and the missense ones are relatively low probability. Certain substitutions are considered to have severe phenotype, others are having mild phenotype. So you can see that these are additional nuances in addition to the standard ACMG criteria that you use to qualify the mutations, and therefore these guidelines on Alport syndrome specifically have to be studied when you are qualifying a variant as a geneticist. In autosomal forms, this kind of classification has less relevance. So whether to test or not to test, like in our young 2-year-old child, did it give us a good thing? Did we do a good thing or a bad thing? Overall, we do feel in the balance we did right by the family, because if they had more siblings with the same problem, they would be even more frustrated having, say, 2 boys with the same disease than they are now, knowing the knowledge that they can at least do testing for the next fetus. Also, they are armed with a way of retarding progression of kidney failure in this boy, because we are using ACE inhibitors to retard kidney failure here. But in, say, in a Western setup, such a boy might be denied insurance coverage because he would be labeled as having a disease. So it's got its pros and its cons. Overall, the indications of genetic testing are listed here, and you can look at a larger text for this. In the interest of time, we'll just skip forth and go forward to a couple of slides. I'll not deal with transplantation concerns which Dr. Ritna would be dealing with, and move on to 2 siblings with hematuria who were evaluated extensively at a private hospital and offered kidney biopsy, scared of which they came to us because these were 2 girls with microscopic hematuria and proteinuria, and the mother was concerned that a kidney biopsy may not be necessary here. She also told us about how this problem has been there for more than a year, and that the father has had 2 kidney transplants performed beginning at age 20. The father was actually blaming the mom for the problems in the girls because he felt that the mother had given birth to 2 defective girls. The family tree is shown here very neatly. Even the grandfather had had kidney failure, as also an aunt. Now, next-gen sequencing revealed the problem lay with the father's side of the problem, family, and this was confirmed by Sanger sequencing in the father, sibling, and the mother, and this was an MYH9 related disease. So MYH9 associated nephropathies can affect the kidneys, the ears, and the eyes, as well as platelets and neutrophils, with a variety of malformations which were clubbed together into various phenotypes. In the older times, they were called with various names like Mayheglin, Sebastian, etc. But now we know that this was associated with MYH9 disease. I'll just quickly glance over a couple of other inherited glomerulopathies which must be kept in mind. You are all very familiar with the C3 glomerulopathies, and you know that we now understand that these can be caused by a variety of complement gene defects such as complement factor H, I, C3, CFB, etc., but also because of rearrangements in that locus CFHR 1 to 5 and CFH, because this is a very, very prone to rearrangements locus. And therefore, an MLPA as well as next-gen sequencing is recommended as the way to go forward when examining patients, particularly in preparation for transplantation. Similar is the scenario with atypical HUS. Fibronectin nephropathy and CFHR5 nephropathies are conditions that I'll gloss over and go over to just leave you with this list of conditions which we must recognize, because these are all inherited glomerular diseases which cause hematuria and proteinuria and have a high risk of kidney failure. The list doesn't really stop here. You have a variety of phenotypes and a variety of causes, and therefore you must be understanding that there is much to know and much to learn as we go forward. Overall, the diagnostic yield of genetic testing is actually higher for glomerulopathies, particularly in children, than it is for steroid-resistant nephrotic syndrome. This is data clubbed together for a variety of studies from across the world, and the median values indicate the mean values in these patients. These obviously can be enriched cohorts similar to the enrichment that I described earlier. Overall, I'll leave you here with this slide, which indicates that genetic testing is important. It would be required in a variety of circumstances, and therefore you must consider genetic testing in these conditions presenting, especially at a young age, with proteinuric or hematuric nephropathies. Thank you. At the outset,
thank you,
ma'am, for giving me this opportunity to participate in this symposium. Thank you, Dr. Madhulika, for illustrating.
So I think the recording is done. And I would like to thank both of you for the excellent talks that you have given. Am I audible? Anybody could say?
Yes. Yeah, you're audible. Yeah.
Okay, thank you. So there is one question which I think should be directed to Dr. Aditi, and that is from Dr. Urmila Anand, which says, what do you do when you have an NGS which throws up a pathological variant which is not expected in the clinical scenario? For example, if you have a collapsing glomerulopathy and patient, and then you have called for A5 variants and the POL1 being negative.
Am I audible?
Yeah, you're.
I think there was some echo there. Thank you for the question. Ma'am, actually, we would come across the scenario sometimes wherein you have an unexpected variation that comes up. Obviously, we would have to kind of review the clinical phenotype as well as the context wherein we have done the testing. For example, in this context, collapsing glomerulopathy and a finding of a COL4A5 change, again, it has to be taken in context of whether this is a male or a female person, what are the electron microscopy findings, whether there is any focal thinning, thickening or not, any basket weaving changes, etc. The pathogenicity of the variant you said was pathogenic, so it is most likely it is relevant even in a female. However, so far as I know, collapsing glomerulopathy has not been reported with Alport syndrome, as you have yourself rightly pointed out. So probably one needs to go back and look at the pathology again. And this is an exercise that you would end up doing very often. Suppose this has really thrown up as a surprise and it is indeed a pathogenic variant. It's a person who would have a risk of progression of disease. You would definitely finding proteinuria due to collapsing, but then you would also expect to find persistent microscopic hematuria if this is indeed Alport syndrome. And if this is a male and it's an adult, you would probably begin to have some sensorineural hearing loss by this time. So review of the clinical phenotype is what one would be doing in this circumstance.
I hope the question is being answered. And
yeah, Joyita, I would just like to add here, though, I mean, this would not be a very common scenario, though
Ma'am, was I audible?
Find it. Yeah, you were audible. You were audible, Aditi, right? You were audible, Aditi.
Sorry. Okay. Okay.
You were audible.
Okay, ma'am.
So, I mean, so we should also keep in mind if it is really diverse. I mean, at times this is at least within the renal, totally unrelated. I mean, totally unrelated phenotype, which we are not able to explain at all. So there I mean, everybody takes care, but swap of samples also needs to be kept in mind whenever we are doing, when we are dealing with this. But then obviously, as Aditi said, going back to the phenotype, from the genotype to the phenotype and going to the details. And as Aditi mentioned earlier, not in this particular case, but you may have something like phenocopies where the same gene may be manifesting as different diseases. So that also has to be kept in mind. Obviously not in this particular phenotype, right? Thank you.
Yeah. So, ma'am, I mean, the collapsing glomerulopathy has not been reported, but definitely FSGS is definitely a possibility with a COL4A5 change. So, so far, I don't think there are any reports of collapsing per se.
Right.
In the same context, can I ask you one question? Like, because you have shown the data of your nephrotic syndrome, the genetic data of your nephrotic syndrome, which said COL4A5 being the second most commonest, I think, pathogenic gene. So do you have any specific features which like differentiate this cohort from the others who have SRNS, for example, microhematuria or the GM changes on each?
Yeah. So Joyita, you know very well how sometimes we don't always have access to electron microscopy, and if it is available, it might also be a large time lag between the time that you do the light microscopy and then you look at the EM. And that's why very often these changes may not have been looked for or looked at. Also, the changes in children might be just focal processes beginning with. So we don't entirely understand. And if you look at all these reports of phenocopy where COL4A5 has been described as phenocopy, it's not just our cohort. Nobody has really gone and described the literature on what the GBM shows. But microscopic hematuria, yes. And by adolescence, they would have sensorineural hearing loss. But we have had really young children presenting with nephrotic state also, like beginning at 2 years of age, with some partial response also. And that is why it becomes very, very important to do electron microscopy in all circumstances, and probably anyway worry around, say, what is so-called partial remission to calcineurin inhibitors, which may not indeed be remission at all.
Thank you. Point well taken. The next question, I think, is just one more question that is for Madam Kabra, and that is, are we maintaining libraries of VUS where we can compare notes in India? What is the next question?
Okay, so this is a very important question, and efforts are going on, as I mentioned in my talk as well, that it's extremely important to have population-based databases. So many labs in the country have large amount of data available with them, and they have data on VOUSs. But then there has been no effort to combine all that data together, which will be really, really useful. But then there have been efforts like from IJIB, and we as a group, particularly Manipal group, coordinated this exercise, and many of us contributed to that database, and that database is available. So, but then it is very important that we collate all the data available from the Indian population so that we can have information on the VOUS, because many of the VOUSs which have been labeled in the foreign databases as VOUS may actually be disease causing in our population if we collate all the information. Thank you.
Thank you. I think there are some more questions coming up. I can always pass it to you and get back with you can get back in
one
the
question
chat
to Dr.
later on, right? Yeah.
So one question,
Yes.
Dr. Madhulika. So basically, as you told, that the yield of clinical, the whole exome sequencing is anytime better than a clinical exome. So when should we actually go for whole exome? Like if the clinical exome yield comes out to be negative, then go for whole exome, or directly we can jump in if finance is not an issue?
Yeah, so more frequently we are moving towards whole exome now, because the cost difference has become less now. So somewhere around 12,000 is the clinical exome, and whole exome is around 15,000. So unless the phenotype is really very specific in the sense in the group, we may have, suppose we are thinking of storage where we haven't been able to find the cause, and we know that clinical exome would cover all the genes, we would order a clinical exome. But then if we are dealing with, say, a neurodegenerative disorder where we do not have clear clues, we will go in for whole exome sequencing. So we are moving more towards whole exome these days, because we may find something new, we might find some new findings also, which may be relevant for the family.
Sure. Thank you.
Okay, thank you.
I think we could go for the next session. Dr. Kanavana could take over.
That's fine.
Thank you.
So for the next session, So for the next session, the topic is case-based genetics in CKD, when to send, what panel, and how to interpret. And for that, we have presentation by Dr. Prajanya Ranganath, who is additional professor and head, Department of Medical Genetics, Nizam Institute of Medical Sciences, Hyderabad. So she has almost more than 85 peer-reviewed papers, a lot of book chapters, as well as she's editor of one of the books. So over to you, madam.
Thank you so much, Dr. Khanna. And at the outset, I'd like to thank the organizing committee for this wonderful opportunity and honor of being a part of this conference. And I request the organizers to play the pre-recorded presentation. Thank you. And I'll take questions in the end. Hi, greetings from Hyderabad. This is Dr. Pragya Ranganath from the Department of Medical Genetics at NIMS, Hyderabad. In this talk, I'll be giving you an overview of how genetic testing is done for chronic kidney diseases and why and when we should do the testing. So basically, a brief background about genetics and CKD. So we know that genetic factors play an important role in the causation of chronic kidney disease. And in fact, monogenic causes account for almost 30% of CKDs in pediatric patients and roughly around 5 to 30% of CKDs in adult patients. About 450 monogenic disorders are known to be associated with various forms of renal involvement. But the main categories of genetic renal diseases would be the genetic renal globulopathies or the podocytopathies, including the SRNSs, which has already been dealt with in the first talk. Also, the genetic renal tubulopathies, the renal ciliopathies, congenital anomalies of the kidney and urinary tract, atypical hemolytic uremic syndromes, certain other miscellaneous conditions. Many of these manifest in the pediatric age group, but we have later onset conditions also which manifest in adulthood. So when should we do genetic testing? So these would be some of the broad indications where genetic testing is indicated. When the clinical laboratory renal imaging and or renal histopathology features are suggestive of a specific monogenic condition. For example, autosomal recessive polycystic kidney disease, autosomal dominant polycystic kidney disease, Alport syndrome, primary hyperoxaluria, etc. So if you have a clinical diagnosis of any such condition in mind, you have to do the relevant genetic testing for confirmation of the diagnosis. Then there are some etiologically heterogeneous conditions where you have non-genetic causes also, but a proportion of cases are known to occur because of genetic causes. So this includes your steroid-resistant nephrotic syndrome, congenital anomalies of the kidney and urinary tract. So for all such conditions also, you would do genetic testing. Then any patient with unexplained CKD, where you're not able to identify any definite acquired etiology, such as an autoimmune cause or some other acquired etiology, where a cause remains unidentified, you can do genetic testing to look for the monogenic causes. And of course, if you have a history of similar pattern of renal involvement in one or more family members, then again, genetic testing is indicated. So why should we do genetic testing? What is the utility of this? So for the patient, of course, the identification of the exact etiology and precise diagnosis helps in accurate prognostication, appropriate management, and also there are some monogenic disorders now for which disease-specific therapies are available. So you can actually start these treatments once you have a confirmed diagnosis following genetic testing. Then you know that many of them have other extrarenal manifestations also. So you can do a surveillance, follow-up monitoring for all these anticipated manifestations and complications. And again, once you have a clear diagnosis established through molecular genetic testing, sometimes you can actually do away with the renal biopsy also. And then in addition to all of this, we know that for some genetic disorders, there is a possibility that if the individual goes into end-stage renal disease and if you go for a renal transplant, there may be a risk of recurrence of disease pathology in the transplanted kidney also. So if you know the underlying etiology, you can even predict this, whether there would be a recurrence of the disease pathology post-transplant. For the family, of course, and of course for the individual, you can provide accurate genetic counseling. You can tell them about the genetic basis of the disease, why it has happened, and also the pattern of inheritance and the risk of recurrence in other family members. Then if it is a serious genetic disorder and especially something which is of pediatric onset, you have the option of offering prenatal or pre-implantation genetic testing to prevent recurrence in other children in the family, in other subsequent family members. Then also carrier testing of family members can be done to determine the risk of recurrence in their offspring. And for some of the later onset disorders like ADPKD, you can actually do pre-symptomatic testing through targeted mutation analysis of other at-risk family members. And when a kidney transplant is planned, especially with a related donor, pre-symptomatic genetic testing helps to confirm the absence of disease or carrier status in the prospective donor, because we know that the donor may actually manifest the symptoms later but may be harboring the pathogenic variant. So obviously then that particular individual would not be suitable as a donor, and you can properly screen for that if you know the exact genetic mutation to look for. So this is an overview of the utility of genetic testing from a recent issue of Kidney International, which nicely sums up why we should do genetic testing for kidney diseases, especially chronic kidney diseases. So because we know that conditions amenable to specific disease modifying therapies may be identified. For example, if you get a diagnosis of Fabry disease, you can start enzyme replacement therapy. Then you have, if cystinosis is diagnosed, then you can actually start the cysteamine therapy. Likewise, for the inherited tubulopathies, once you have a clear diagnosis identified, you can properly plan the management. Then again, some of the conditions are amenable to non-specific renoprotective strategies also. For example, RAS blockade for Alport syndrome. Then you can also, once you have a clear diagnosis and you have definitively ruled out autoimmune etiology by establishing that there is a genetic basis, you can actually avoid unnecessary interventions, and also prolonged immunosuppressive therapies post transplant can be avoided. Then in addition, conditions at risk for recurrence after kidney transplantation can be determined, as already previously mentioned. For example, in some of the atypical hemolytic uremic syndromes, primary hyperoxaluria, and certain other conditions, we know that there is a risk of recurrence in the transplanted kidney. So you could probably avoid transplant there or do some other modifications pre-transplant to reduce the risk of recurrence. And then for many of them, there may be extrarenal manifestations. So if you know the diagnosis, you can monitor for those. And again, as previously mentioned, you can actually do proper reproductive counseling and give them the options of prenatal pre-implantation genetic testing to prevent recurrence. Now, how would you go about doing genetic testing? So before we actually embark on this process of genetic testing, phenotype delineation is very, very important. So a thorough phenotype delineation is essential for every patient wherein you're suspecting a genetic etiology. So detailed history, including especially for pediatric age group patients, prenatal, perinatal, neonatal events you ask for, developmental milestones. Then a detailed family history, minimum 3-generation pedigree is essential. Thorough dysmorphology evaluation, head-to-toe evaluation, systemic examination, and all the relevant lab investigations and imaging studies have to be done. Because in spite of the availability of advanced testing technologies, we know that your thorough clinical examination and analysis based on clinical acumen remain very, very important tools in the diagnosis and management of genetic disorders. And also, a thorough phenotype delineation is absolutely essential if you actually want to accurately interpret your genetic reports. So if you look at the etiology of chronic kidney diseases, it actually is a spectrum. Some of them may be purely acquired conditions, for example, post-recurrent infections. Some of them may be purely genetic, and those are the ones that we are looking at in this particular talk, where they could be caused by specific mutations in individual genes or by chromosomal copy number variations. And then we have a gray area in between of the multifactorial conditions. In fact, many of the chronic kidney diseases and many of the other chronic medical conditions, including hypertension, diabetes, autoimmune disorders, actually have a multifactorial etiology, where there is a combination of genetic and environmental factors, and all of them together actually contribute to the causation of the disease. So generally, when we talk about genetic testing for CKDs, we are mainly looking at this group, the purely genetic disorders. We generally do not recommend testing for the polygenic multifactorial conditions, because there are so many factors contributing to the etiology there. The testing for individual gene mutations really doesn't have much clinical significance and utility in terms of management or further testing and so on. So if you look at the types of purely genetic disorders, you could have gross chromosomal anomalies, you could have chromosomal microdeletions and microduplications, and then you have the monogenic disorders where the mutations are within individual genes. So the type of genetic testing would differ depending upon the type of genetic disorder. So for the gross chromosomal anomalies, we do the cytogenetic tests, especially karyotyping. For the microdeletions, the copy number variations, we do something called molecular cytogenetic tests, which includes tests like FISH, MLPA, and microarray. And then for the single gene disorders, we do something called molecular genetic tests. As most of the chronic kidney diseases are single gene disorders, for most of them, we do molecular genetic testing. So molecular genetic testing, again, there are so many different types. The main ones would be Sanger sequencing, MLPA, that is multiplex ligation dependent probe amplification, and next generation sequencing. Sanger sequencing is the conventional method which has been around for a long time, where you do PCR amplification of individual exons of the gene, and then you sequence these individual amplified parts, because majority of the mutations lie in the coding regions of the genes or in the flanking exon-intron junctions. Usually we sequence these regions, and intronic regions are sequenced only in a select few cases. After the sequencing is done, you check the sequences, you compare it with the reference sequence, and you try to identify the mutation. So this is what a capillary sequencer looks like, which is used for Sanger sequencing. And this is what your Sanger sequence would look like. And we compare it to the reference sequence to see where the difference lies. So Sanger sequencing is suitable for sequencing of small single genes which are less than 10 exons in size to look for known specific disease-causing mutations, validation of variants which have been already identified through the NGS method, and also when you want to look for that particular variant which has been identified in the index case in the proband in other family members, such as for carrier testing purposes, or for pre-symptomatic testing, or for prenatal genetic testing, then we can do targeted testing through Sanger sequencing for that particular variant alone in the family member. Next generation sequencing is what is now most commonly used for testing of the CKDs. It is a massively parallel sequencing strategy which is used to sequence large portions of the genome simultaneously. And for large genomic portions, it is very good because it can be done at a much lower cost and in much lesser time than Sanger sequencing. So there are various steps involved in NGS, and the main NGS-based testing approaches are multi-gene panel testing, where you can do simultaneous sequencing of multiple genes associated with a specific phenotype. Example, the renal tubulopathies panel, or the SRNS panel, or the atypical HUS panel. Or you could go with something called clinical exome or focused exome or Mendelium sequencing, where sequencing is done for the coding portions, that is the exons, of all the genes associated with known disease phenotypes, which are listed in the OMIM database, that is Online Mendelian Inheritance in Man. Or you could do whole exome sequencing, where you do sequencing of all the genes, exons of all the genes, that is the entire coding portion of the genome. So when we say exons, actually we also include the intron exon junctions, because that's where the splice sites lie, which I'll be talking about in one of my subsequent slides. And whole genome sequencing is where you sequence the entire genome. So NGS is actually suitable for sequencing large genes, for sequencing multiple genes. And in fact, for many of the CKDs, we know that the same disease phenotype can be caused by any one of many different genes. For example, SRNS, idiopathies, and so on. So these are the genetically heterogeneous conditions. And NGS is definitely the best modality at present to sequence these genes. And other sometimes you have overlapping disease phenotypes also, and it is very difficult to say that you have to actually check this gene only. So even in such scenarios, NGS helps you. And then of course, MLPA is the other technique which is used for molecular genetic testing, and this is specifically used for detecting large exonic deletions and duplications. So, and also it can be used for chromosomal copy number variations when you want to look for specific microdeletions or microduplications. And then the tests which are used for cytogenetic and for chromosomal anomalies are the cytogenetic and molecular cytogenetic tests, which I already spoke about. So with that brief background, I'll be moving on to the clinical scenarios. So I'll begin with this family. So this was a 6 years old male child who was a third born to third degree consanguineous parents. His presenting features were short stature, failure to thrive, recurrent vomiting, and he was being actually treated as rickets by 2 or 3 pediatricians outside. When we asked about the history further, we found that the child had history of polyuria and polydipsia noted since about 6 months of age. There was also some doubtful history of photophobia. The parents were not very sure about that for the past 1 year. There was mild motor delay, but otherwise the intellect was normal. On examination, the child had significant short stature, -4 standard deviations below mean for age and sex. The weight was also below the third centile, and he had bilateral genovalgum and wrist widening. And there was also history of death of an elder sibling at 8 years of age with similar features. However, unfortunately, that child had not been properly evaluated. So when we did the investigations for this child, we found that the serum creatinine was above range. And then there was trace proteinuria, there was glycosuria as well. There was significant hypokalemia, also hyponatremia, and chloride was below normal range. Hypocalcemia was there, phosphorus was low, alkaline phosphatase was mildly elevated. There was evidence of metabolic acidosis in the blood gas analysis. The x-rays were suggestive of rickets, and ultrasound KUB was normal. There was no evidence of any nephrocalcinosis, nephrolithiasis, or any other specific renal changes. Complete ophthalmology evaluation had been done previously, and that was reported to be normal somewhere outside, but a repeat evaluation was advised. So based on the clinical features and the investigation findings, the overall impression was that of chronic kidney disease with renal Fanconi syndrome with renal rickets, most likely monogenic etiology because an elder sibling was also affected, and possible diagnosis was nephropathic cystinosis. But the point against was that at least the ophthal evaluation report which was available, no ocular findings were reported. Other monogenic causes of renal Fanconi syndrome include Lowe syndrome, DENT, galactosemia, glycogen storage disease type 1, hereditary fructose intolerance, Wilson disease, and Fanconi-Bickel syndrome. The child did not really have features corresponding to any of these other syndromes. But then we also know that there are some monogenic non-syndromic renotubular Fanconi syndromes also. So it could even be one of them. So molecular genetic testing for confirmation of the diagnosis is definitely recommended here. And that was what was done. So the testing options here would be, of course, we know that we have to do an NGS-based analysis because we have to look at not only the cystinosis-related gene, but also rule out the other monogenic causes of renal Fanconi syndrome. So rather than do Sanger sequencing for the cystinosis-related CTNS gene alone, it's best to go for a broader spectrum testing. But which broad spectrum testing would you go for? Would you go for a multi-gene panel or a clinical or focused exome sequencing or whole exome sequencing? So in this scenario, whole exome may not really be required. It would be okay to go with a multi-gene panel or a clinical exome sequencing because we have a specific set of conditions, a specific set of differentials in mind. So in this child, clinical exome sequencing was done and we found a pathogenic variant in the CTNS gene. So the diagnosis was CTNS associated nephropathic cystinosis. And now that we have the diagnosis established, we can do the proper appropriate management in terms of, in addition to the general supportive care of correction of acidosis, potassium chloride replacement, calcium, phosphorus, vitamin D3 supplements, and other supportive care. The good thing is that we have a disease-specific therapy available in the form of cysteine depletion therapy with oral cysteamine bitartrate, which is marketed under the trade name of Cystagon. And we also have cysteamine hydrochloride eye drops available. Actually, they can be, though they're not really marketed in India, they can be imported. And there are agencies available which help with this process. And Cystagon is not very expensive. It is fairly affordable. So that was what was done for this patient. The cysteamine therapy was initiated and the child is under follow-up. So you can also give a proper prognosis, do a regular follow-up for the child. Of course, some of them, if they're given cysteamine from an early age and appropriately, some of them, the age of onset of ESRD can be significantly delayed. But if they end up in ESRD, renal transplant may be eventually required. Then with the proper diagnosis, you can do appropriate genetic counseling of the family, and you can actually offer the options of prenatal genetic testing or even pre-implantation genetic testing if the couple plan for any future pregnancies. So that was about this child. But since we have discussed this particular report, I thought I'll take this opportunity to give you a sort of an insight into how a genetic report can be interpreted and what is the meaning of all the different terms which are mentioned in a genetic report. So here we know that to begin with, they have this particular thing, gene, transcript, and location. So what does this mean? So transcription, we know, is the process of copying a segment of DNA into the complementary RNA. And the gene transcript is nothing but the mRNA sequence, which is synthesized from a gene sequence. So why do we need to mention the transcript ID here? That's because alternate gene transcripts may sometimes be there from the same gene. That is to say, different mRNA sequences may be synthesized from a single gene. If you look at it here, you can see that whatever is present in exon 3 in the gene, in the different transcripts, the actual position of the particular variant may differ. So over here, you may have this variant in this position. In transcript 2, it may be at the actual position may be different. In transcript 3, it may be the nucleotide position where the variant is will differ. So even though the variant is the same, the position of the variant may differ. The new numbering of that variant may differ between different transcripts. That's why it's very important to actually mention the transcript ID and also always check the transcript ID when you are actually referring to a particular variant. Because as I said, position or number of the variant, the numbering of the variant can differ in different transcripts. So each transcript is given a unique identifier or accession number called the transcript ID. And that is something like the address of the gene, the exact street number. Okay. As you would say in an address, it's something like that. The street number, house number, that's what this refers to when we are talking about a variant. So then moving on, the next part is about the location of the variant. So we know that a gene is made up of different portions. There are exons, then there are introns, then you have something called a promoter region, then you have something called a transcription start site, then you have a 5' untranslated region and a 3' untranslated region. So whenever the variant is described, the position of the variant in the gene is also mentioned. So what are exons? Exons are actually portions of the genes that code for the amino acids, and they are retained in the mature mRNA following post-transcriptional splicing. Whereas introns are the portions of the gene that do not code for the amino acids, and these are not retained in the mature mRNA following post-transcriptional splicing. Splicing is the process of removing the introns. So the junctions of the exonic and the intronic sequences where splicing occurs are called as splice junctions or the splice sites. So that was about the location. Now coming to the variant per se. So variant, what do you mean by a variant? So previously the term mutation was used. Even now, of course, it's quite commonly used. So this is the term, it's a conventional term which is used to refer to a permanent alteration in the nucleotide sequence of the genome of an organism. And genetic variant or variation is just any difference in the DNA sequence of an individual when compared to the reference genome sequence. So the term mutation and variant are often used interchangeably. Okay. So now when we call, so this is the next part of the report where the zygosity is mentioned. So here it is written as homozygous. So what do you mean by the zygosity? So we know that every gene is present in 2 copies, or rather more, except for the X-linked genes in male individuals. For all other genes, there are 2 copies in each normal individual. So between the 2 copies of the gene that are called alleles. So between the 2 alleles, if one of the alleles has the variant is said to be present in a heterozygous form. If both the alleles have the same identical variant, the variant is said to be present in a homozygous form. If the 2 alleles have variants, but at 2 different positions and 2 different variants are present in the 2 alleles of the same gene, then the variants are said to be present in compound heterozygous form. And for X-linked genes in male individuals, where normally only 1 copy of the gene is present, if that single copy has the variant, the individual is said to be hemizygous for the variant. So autosomal dominant disorders, the individual will be heterozygous for the pathogenic variant. For autosomal recessive disorders, affected individuals will be either having homozygous pathogenic variants or compound heterozygous pathogenic variants, whereas the carriers will be heterozygous. For X-linked disorders, affected males will be hemizygous for the pathogenic variant. Carrier females will be heterozygous, and affected females for X-linked dominant disorders will be heterozygous. They will have 1 copy of the variant only. The other allele would be normal, but because it is an X-linked dominant disorder, the single allele, the single mutation itself will result in the manifestations in the female who has that heterozygous variant. So these are the different types of genetic variations that can occur: substitutions, deletions, duplications, insertions, inversions, and repeat expansions. So substitution is nothing but one nucleotide being replaced by another nucleotide. These were the ones which were previously called point mutations, but the preferred terminology now is single nucleotide variant. So there are different kinds of SNVs. You can have missense variants, nonsense variants, synonymous variants. And if the substitution occurs at a splice site, it alters the splicing, in which case it's called a splice site variant. So in missense variants, substitution of one nucleotide by another leads to replacement of one amino acid by another. In a synonymous variant, in spite of the substitution, the mutated codon codes for the same amino acid, and therefore there is no change in the amino acid sequence. In nonsense variants, substitution of one nucleotide by another leads to replacement of the amino acid coding codon by a stop codon. So the translation stops there. And there can be small insertions and deletions also. It could be of one or a few nucleotides. When it is present in multiples of 3, the reading frame may be intact. But when it is not in multiples of 3, it leads to a shift in the reading frame. And then that's when we call them frame shift mutations. So here you can see insertion of one single nucleotide has resulted in a shift in the reading frame, and therefore all the amino acids distal to that insertion are different. Similarly, deletion of one nucleotide here has resulted in a shift of the reading frame, and all the amino acids distal to that are altered. So small deletions are generally like this, where you have one or few nucleotides missing. But sometimes you can have large intragenic deletions or duplications also, where the entire exon or multiple exons may be deleted or duplicated. So those are the ones we call exonic deletions or duplications. So generally, nonsense variants and frameshift variants tend to be pathogenic, disease-causing. Missense variants may or may not alter the protein function. Some of them may be accordingly pathogenic, some may be benign. Synonymous variants usually do not cause a change in the protein sequence, and therefore they are usually benign. Of course, there are always exceptions to these rules. Then again, depending upon the position of the variant, variants within exons tend to be more often disease-causing. Likewise, variants at splice sites tend to be disease-causing. But the deep intronic variants, which are usually, they do not contribute to the coding portion, and therefore they're usually benign. But sometimes they can also be disease-causing if they create a new splice site, which is called activation of a cryptic splice site, and they can alter splicing and thereby cause disease. So in this particular child, we had this variant. This is a missense variant, but it is a known pathogenic variant because the nucleotide substitution is resulting in serine being substituted by phenylalanine. Then there are specific guidelines followed for the notation of the variants, which are most of us follow this Human Genome Variation Society guidelines, and there are recommendations given for notation for the nucleotide variants as well as for the amino acid, that is a protein variants. Next, moving on to the inheritance patterns, we know that depending upon the mutation identified and which gene you have identified it in, you can identify the exact inheritance pattern. So the Mendelian inheritance patterns include autosomal dominant, autosomal recessive, X-linked and Y-linked. Now you can see I have written X-linked here because for X-linked disorders, there is actually a spectrum of manifestations in females. Females may be sometimes completely asymptomatic carriers, and sometimes they can manifest disease almost to the same extent and severity as the males. And therefore, nowadays, it's preferred to use the term X-linked rather than recessive, dominant, X-linked, recessive, X-linked, dominant, X-linked, semi-dominant, and so on. Then there are certain non-Mendelian patterns of inheritance also, such as mitochondrial inheritance and disorders of imprinting, one of the examples being Prader-Willi-Engelmann syndrome. Then oligogenic inheritance, where mutations in more than one gene together contribute to the disease. So mutations may have to be present in 2 genes or even sometimes 3 genes for the disease to happen. So one of the classic examples given is for Bardet-Biedl syndrome, certain types, where mutations may be present in 2, BBS2 and BBS6 together to cause the disease. So in this particular child, for cystinosis, it follows a typical autosomal recessive pattern of inheritance with a 25% risk of recurrence in each offspring of a carrier couple. Then finally, moving on to this last column, that is a classification of the variant. Now here it is classified as pathogenic, and I'm sure all of you must be seeing these kind of reports and looking at these variant classifications. Of course, many of you would be familiar with what that means, but for those of you who do not know what this classification is, I'll just take you briefly through how we normally analyze variants. So normally when we do broad spectrum tests like next generation sequencing based testing, you identify thousands of gene variants. And especially if you were to do something like a whole genome sequencing, you may actually identify lakhs of variants also. So you actually have to filter through these, you have to sift through these variants. And for this, we take the help of databases. So we check known databases, databases of known disease-causing variants, databases of known polymorphic variants. So polymorphic variants are generally, these are the ones which are present in the general population also, and therefore they are more likely to be harmless and benign variants. So the known mutation databases that we often use are HGMD and ClinVar. The population databases that we often use for checking for polymorphic variants include 1000 Genomes and Genomedi. There are many others as well. Then after all of this, you narrow down the list of variants and then you see which of them matches well with the patient's phenotype. That's why I said in the beginning, thorough phenotype delineation is absolutely important if you want a better genetic report. And then after you have identified all these potential variants, you actually can look at these variants, the in silico predictions. So we have something called mutation prediction software, wherein you can put the variant and you can actually get some results as to whether the variant is likely to be disease causing, likely to be benign, and so on. And finally, you would also get the further evidence by checking the familial segregation pattern of the variant by testing it in the parents, the siblings, and so on. So these are some of the mutation prediction software which are used for in silico analysis, mutation taster, polyphen2, and SIFT. And this is how we do a familial segregation analysis of the variant. Now here, as you can see, this is the proband, and this is an autosomal recessive disorder. So we expect the parents to be heterozygous carriers. The proband should be homozygous for this variant, and the siblings who are unaffected could either be heterozygous carriers or should not have the mutation at all. So if your variant satisfies this pattern, then we know that that is consistent with the expected Mendelian segregation pattern for this particular disease. So you can see here that both parents are clearly heterozygous for the variant. The proband is homozygous for the variant. One unaffected sibling is heterozygous and one unaffected sibling does not have the mutation at all. So here it is satisfying your expected Mendelian segregation pattern. So classification of sequence variants, the standard guidelines which are used are the ones given by the American College of Medical Genetics and Genomics and the Association for Molecular Pathology, as per which the variants are classified as pathogenic, likely pathogenic, of uncertain significance, likely benign, and benign. Generally, pathogenic, likely pathogenic gene variants which match your phenotype can be considered to be diagnostic, especially if they follow the expected Mendelian segregation pattern in the family. So pathogenic variants, you have sufficient evidence that the variant is causative for the disease phenotype based on previous reports in other patients and other functional studies, including animal model studies or cell line based studies and so on. Likely pathogenic, there is a very high chance that the variant is disease causing, but additional evidence is expected to confirm the pathogenicity further. A variant of uncertain significance is one where you cannot definitively classify it to be contributory or non-contributory to the disease phenotype based on the currently available information, and you may have to look for further levels of evidence to get a better clarity. Likely benign, the variant is most likely not of clinical significance, but currently available scientific evidence is insufficient to prove this conclusively. And benign variants are one where you have sufficient evidence that the variant does not have any clinical significance. So as I said, what we generally consider to be disease causing are the pathogenic and the likely pathogenic variants which match your disease phenotype. So now I'll move on to the next patient. So this was a male patient who presented at 39 years of age. He had hypertension, one episode of CVA, and skin angiokeratomas were noted. There was also history of CVA and chronic kidney disease in an elder male sibling who later died at 46 years of age. The nephew, who was initially at that point of time, had only he was 15 years old, and there was a diagnosis of vortex keratopathy made in him, but he did not have any renal manifestations. Then the investigations, when they were done initially, showed only a mild elevation of creatinine, and there was some, but the ultrasound abdomen showed significant renal parenchymal disease, grade 3 to grade 4. And based on all of this, because if you look at the pedigree is very typical for an X-linked inheritance pattern, where two individuals are affected and then the sister's son as well, right? So this is very much consistent with X-linked inheritance. So putting everything together, Fabry disease is the most likely diagnosis. So therefore, here, because we have a definite diagnosis in mind, and the specific gene is known to be associated with this condition, that is a GLA gene, which codes for alpha galactosidase. So Sanger sequencing was directly done for this GLA gene, and a variant was found. This is a hemizygous variant. We are saying hemizygous because this is a male individual with the variant, therefore. And the variant, however, was initially classified as a variant of uncertain significance based on some of the criteria that the ACMG guidelines use. But, so you can see here, initially classified as a variant of uncertain significance. In fact, this website called Intervar, a resource that we use, wherein you can actually identify, you can get a classification of the variants once you put in the proper details into that thing. So now we have got a variant which is classified as a variant of uncertain significance. We need additional evidence to ascertain the pathogenicity of the variant. One thing, of course, is that there is a definite phenotypic match with Fabry disease. So that is at least clear. Now, further levels of evidence, what can we look for? Because this is Fabry disease, at least we have other definitive test available in the form of an enzyme assay. So alpha galactosidase enzyme assay was done, and that showed a clear low level of the enzyme. Then Mendelian segregation pattern was also checked, and the variant was found to be present in the affected elder brother, in the affected nephew, in the carrier sister, and in the carrier mother also. The variant was actually absent in the eldest sister, who was herself normal. Her children were also normal. Interestingly, the youngest brother, who was 35 years old at that time and was asymptomatic, apparently asymptomatic, also was found to have the variant. And further evaluation of this youngest brother, who was at that point of time asymptomatic, revealed that he did have proteinuria, but he did not have any further renal involvement at that point of time. So now, after getting this additional evidence, you can see we have ticked two more boxes here, because you can do manual adjustment based on the additional evidence. So now you know that the variant co-segregates with the disease in multiple affected family members, and we have a definite evidence in the form of an enzyme assay report available. So after this adjustment, Now you see the variant is getting classified as likely pathogenic once we got this additional levels of evidence. So now you are definitely sure about your diagnosis. So now having confirmed the diagnosis, the patient was actually started on enzyme replacement therapy. Fortunately, he was able to get this therapy through the charitable access program of the pharma company. And he's actually on ERT for the past 7 years. Unfortunately, he's not doing so well. His renal functions are deteriorating, and in fact, he developed end-stage renal disease, and he's been on dialysis since December 2019. And even his cardiac problems have been progressing. He's now developed concentric LV hypertrophy, and but overall, his cardiac ejection fraction continues to remain okay. So ERT probably has not benefited him much because it was started later in the course of the illness, and also the evidence for long-term benefits of ERT remains to be proven. The nephew also was fortunate enough to get the ERT on the charitable access program basis. At the time of starting his ERT, he had mild proteinuria and of course the vortex keratopathy, and there has been no further progression in the past 7 years. The sister, this boy's mother, and the sister of the proband also has mild proteinuria. And we know that milder manifestations of Fabry disease and many other X-linked disorders can happen in female carriers, and sometimes they can have more severe manifestations as well. So we should not assume that they're just female carriers and not evaluate them at all. They should also be appropriately evaluated and kept under follow-up. Moving on to the next patient, patient 3, who's a 2 years, 4 months old male child who had recurrent urinary tract infections. Bilateral grade 3, grade 4 psychoureteric reflux was present. Bilateral renal scarring was found to be there. Then further, we found the pedigree was and the family history was taken. There was history of 2 first trimester abortions in the parents previous to the birth of this child. And there was no other similarly affected family member. Then we did a detailed clinical evaluation in the form of developmental evaluation, dysmorphology evaluation, systemic examination, and so on. And we found that the child also had global developmental delay. All the growth parameters were below the 3rd centile. There was microcephaly as well, facial dysmorphism. There was a cardiac murmur, bilateral polydactyly was there in both hands, bilateral undescended testes was there. There was even an umbilical hernia. 2D echo revealed ostium secundum ASD, MRI brain was normal. So these are the images of the child. You can appreciate the facial dysmorphism and the polydactyly. However, the dysmorphic features were not very typical for any definite dysmorphic syndrome. That's why, what test would you do here now? You have a child who is dysmorphic, who has VUR with associated developmental delay, with associated cardiac anomaly. So in such a scenario, chromosomal microarray would be the best test to go for, because it scans the entire genome for microdeletions and microduplications. And it's very useful to do this test when you do not know the exact CNV to be looked for. And in fact, it is recommended as the first line of genetic investigation for all the unexplained intellectual disability children and multiple malformation syndrome individuals. The diagnostic yield and unexplained intellectual disability, multiple malformation conditions could be as high as 15 to 20%. So in this child, we were able to identify copy number variations in the form of gains on chromosome 4 and deletions on chromosome 11. So here now for this child, multidisciplinary management would be recommended in the form of regular nephrology follow-up, VUR management, cardiology follow-up would also be required, and occupational and speech therapy to help with this developmental issues. Karyotyping of both the parents would be recommended here to look for balanced chromosomal rearrangements, because sometimes if one of the parents is a carrier of a rearrangement, he or she per se would be normal, but there would be a risk of recurrence of up to 30 to 50% of risk of recurrence of chromosomal anomaly in each subsequent pregnancy. If, however, the karyotypes of the parents are normal, then it is likely to be a de novo variation in the child, or sometimes there's also something called gonadal mosaicism in one of the parents, because of which the risk of recurrence may be up to 1%, but usually not higher than that. So accordingly now, after evaluation of the parents, appropriate genetic counseling can be done for them, and prenatal genetic testing can be recommended if they plan for further pregnancies. And now finally moving on to the last clinical scenario. So here we have a 25 years old Naimi Gravida who presented at about 6 weeks of gestation of her first pregnancy. She was concerned because there was history of hematuria, deafness, and chronic kidney disease in her younger brother, and history of death of a maternal uncle due to end-stage renal disease at about 30 years of age. He also had deafness, and she was very concerned about the risk of recurrence of this particular disorder in her offspring, and she wanted to know whether there would be any prenatal genetic testing options available for her to prevent the birth of an affected child. So looking at the pedigree and also the family, the history and the clinical manifestations of the affected individuals, the very likely diagnosis here is X-linked Alport syndrome. So, however, we have to remember that if we have to do carrier testing for this lady or offer prenatal testing for her pregnancy, confirmation of the diagnosis and identification of the exact disease-causing variants in the affected proband, in the affected individual, is the first essential step. Therefore, clinical exome sequencing was first done for the affected brother. This revealed a hemizygous pathogenic nonsense variant in the COL4A5 gene. And when this lady was tested through targeted, so as I said, once we know the mutation, we can do targeted Sanger sequencing for that particular variant in the other at-risk family members. So that was what was done for this lady. And as you can see, she's found to be heterozygous for this variant. One allele is normal and the other allele has the variant. That's why you have two peaks here. So we confirm that she's a heterozygous carrier. And further, though she was asymptomatic, because we know that ladies who are carriers can also have manifestations ranging from mild to severe, we did a further detailed evaluation for her. She was found to have microscopic hematuria, but otherwise her ultrasound KUB and renal functions were normal. So appropriate genetic counseling could be offered. And we know that there is a 50% risk of each offspring of this lady inheriting the pathogenic variant. Now, if it's a male child who gets the variation, the child will have the typical X-linked Alport syndrome phenotype. If it's a female child who inherits a mutation, there could be variable manifestations ranging from sometimes asymptomatic to only mild hematuria to sometimes even very severe end-stage renal disease. So based on this, chorionic villus sampling was done at 13 weeks of gestation. So this is how we do the procedure. So you can see under ultrasound guidance, the needle is put into the CVS and the CVS DNA is extracted and the particular variant is tested in that. And fortunately, that particular pregnancy was negative. The CVS DNA was negative for the variant. Hence, the fetus was not likely to be affected. And the lady was reassured and she continued the pregnancy. So please remember that whenever we are thinking of doing prenatal, pre-implantation genetic testing for recurrence in the family, it is absolutely essential to identify the exact disease-causing variants first. Because in the fetal sample, when you're looking for recurrence, you would do only targeted testing for the particular identified variant. You would never do direct testing, sequencing of all possible genes, because that's subject to a lot of interpretation errors. You may get lots of variants of uncertain significance. You wouldn't know what to do with that, and that will lead to a lot of confusion. So I'll conclude here with the following key messages: that many chronic kidney diseases, especially those presenting in childhood, have a genetic basis. A detailed family history is essential in every CKD patient, especially when you do not have an identifiable acquired etiology. Clinical and lab evaluation for extrarenal manifestations is always a must. Many CKDs are genetically heterogeneous, and therefore next generation sequencing based testing would be the most cost effective with the best diagnostic yield. However, please remember that a thorough phenotype delineation, including all the clinical features and all the relevant investigations, is essential before genetic testing in order to decide which genetic testing would be appropriate for that clinical scenario, and also for accurate interpretation of your genetic test results. And again, for accurate interpretation of the tests and for genetic counseling, clinical genetics consultation is always recommended. And finally, of course, an accurate genetic diagnosis is essential for appropriate management, accurate prognostication, and appropriate genetic counseling. Thank you very much for your patient listening, and I'll be taking questions. Thank you.
Thank you very much, Dr. Pajanya, for the nice lecture, and very rightly emphasizing that the need of genetic testing in children with CKD or the people with CKD, where you do not know the underlying cause, because it not only helps you in your diagnosis of the basically the genetic diagnosis, in addition to the phenotypic diagnosis for which you are managing the child, like for the child with cystinosis, and it also helps in screening of your you can say the non-symptomatic individuals in the family. Plus, it also helps in the prognostication as well as prenatal testings. So that is a great need for the genetic testing in children with CKD. So there's one question which from Dr. Urmila Anand. How does position and numbering of the variant matter?
Yeah. So numbering of the variant is important because, as I showed you in one of the slides, there are different transcripts from the same gene. So if you get a particular variant with a particular number in your report, you may check literature to see whether that variant is already reported or not. And in fact, you may find that what you see in the variant databases is not matching with the numbering of the variant in your report. That may be because in the database, they may have used a different transcript ID, and in your report, it may be a different transcript ID. So just to know that whatever you're looking at is absolutely the same variant. And even in publications, even as I said, when you're checking variant databases and all, to know for sure that this is the variant that is being referred to, it is necessary to mention the transcript ID. Because ID to ID, the position of the numbering of the variant could differ, even though if it's exactly the same variant.
Can I ask a question? Am I audible, Dr. Pranjana?
Yes, yes, yes. I
Yeah,
can hear you.
Yeah, so this is Dr. Manisha. I just wanted to know, see, all of us are here now, and all of us are facing this VUS. Lot of genetic reports are showing variant of uncertain significance. So can we, use this platform to make an online database where we can all share the VUS reports? Because many of the VUS may be common to our population in India and not described in the Western world. So is there anything available like that, or should we start one?
So, Dr. Manisha, that's a very relevant thing, and definitely that needs to be done. And as Madhulika Madam already mentioned at the end of her talk, there are a lot of efforts ongoing now to have a proper compiled database of the Indian variants, because most often what we are doing now is we are looking at databases of other populations, the 1,000 genomes, the Genome, whatever I mentioned and Madhulika Madam had mentioned, includes people from other populations, other ethnic origins. It is not very representative of the Indian population. So there are a lot of efforts ongoing now from the DBT, CSIR, and all of them are taking certain initiatives to have a proper Indian database. And in fact, the CSIR IGIB Institute in Delhi has been working on this for some time. And DBT is also looking to create a good database of Indian variants. So there are steps in this direction. Hopefully, in the next few years, we should have a good database of Indian variants. And when that happens, I think many of these VUSs, many of these variants which are now being classified as VUSs because we don't know about the existence of these variants in our population, may get reclassified. Some of these variants we may end up finding are just polymorphic variants for our population and may end up getting reclassified as likely benign. And some of them we may be able to clearly establish that they're not present in our population. And that might be one of the points towards their pathogenicity. That would not be the only point establishing them as pathogenic. That would be one of the contributory things. So yes, this is definitely the need of the hour, and there are steps in this direction which are going on. And hopefully we should have some good Indian databases within the next few years.
Thank you. So till that is done, can we refer somewhere for information? If we are stuck with a patient of VUS, how do we proceed there?
Yeah. So as I mentioned, again, another thing is, though they are not available in the public domain, many of these labs in India, which have been doing testing for a long time, they have their own internal databases and of thousands of patients. So many of them actually look at their own internal databases also to look for the frequency of these variants in there. It's called a minor allele frequency. So they do check that, and they usually mention that in the reports. That's one of the pointers.
You're muted.
Yeah. Am I audible now?
Yes, you are.
Yeah. Right. And the other point is, but in spite of that, and even in populations which have good databases representative of their population, still a lot of variants continue to remain variants of uncertain significance. Now, to an extent, we can do some further things in the sense, like, for example, I showed you the representative case of that Fabry family, where we were able to, because luckily for Fabry, we have an enzyme assay which kind of, corroborates the diagnosis. And likewise, you check the Mendelian segregation pattern and see if it is consistent with that. And then where you do not have a more definitive corroborative test, you can at least look at the in silico predictions. And in certain cases, you could probably go before the genetic testing, you would have probably withheld the renal biopsy, but maybe after the testing, you could do a biopsy to look for some pathognomonic changes if they are expected for that condition. So that sort of a thing can always be done, but yes, it doesn't always work for all conditions. For a lot of cases, a VUS remains a VUS, and you really can't help it until such time as maybe if you were to follow up that after, let's say, a year or so, you may find that that same variant has been reported elsewhere in other patients and has been actually updated in the databases. And that at that point of time, you would be a little more certain that, yes, this variant which was reported in my patient is now also listed in the database, is also reported in another patient. So hence it is more likely to be, it's a likely pathogenic variant. So that sort of a thing. So that actually requires reanalysis or a review of the databases at periodic intervals. So all those things have to be done in such cases. But yeah, at the end of the day, a lot of these variants just continue to remain of uncertain significance. And it's practically not possible to. So one of the ways of ascertaining whether a variant is pathogenic is by doing functional studies, cell line based studies or animal model based studies. But obviously, it's not feasible in a clinical setting. So therefore, yeah, sometimes we have to leave it at a VUS thing. But then on the balance, looking at the clinical phenotype, how much it matches the Mendelian segregation pattern and all that, sometimes we decide to go ahead with the VUS as the diagnostic thing, and we say most likely this is the diagnostic variant after all the analysis and interpretation is done.
Thank you, Dr. Pranjana. Excellent session. I mean, all talks were excellent and we really benefited. Thanks.
Thank you, Dr. Manisha. Thank you so much.
There's one more question for Dr. Urmila. What are the advantages of chromosomal microarray over whole exome sequencing? Like, when do we prefer which one?
Yeah. So, ma'am, microarray is the test of choice when we are suspecting a chromosomal disorder, chromosomal copy number variation, a microdeletion or a microduplication, because whole exome sequencing it's basically a sequencing-based test, which is essentially meant for single gene disorders, for sequence variants and single gene disorders. And therefore, when you're suspecting a chromosomal disorder, we prefer a microarray. Having said that, we know that nowadays there are good software tools available where looking at the WES data itself, you can determine, or at least you can get an idea whether there might be a copy number variation present by looking at the WES data itself. But then further for confirmation, because WES NGS is still not considered a standard tool for larger exonic deletions, duplications, for these chromosomal copy number variations. So if you get something in WES also, you're supposed to confirm it with microarray. And as such, upfront, if your clinical phenotype is more in favor of a chromosomal anomaly, as I showed in one of those case scenarios, you could go with microarray as the first line test there.
Fine.
I hope that answers your question.
There's one more question by Dr. Payal. So with balanced chromosomal rearrangements in either parent, risk of recurrence is mentioned as 30 to 50%. So does it follow a typical Mendelian inheritance?
No. So chromosomal anomalies do not follow Mendelian inheritance. Mendelian inheritance is meant only for monogenic disorders, where mutations are there in individual single genes. So chromosomal arrangements, when one of the parents is a carrier, there is a 30 to 50% risk of the chromosomal imbalance in each gamete. Again, that can result in various outcomes. It can result in an early abortion or an anomaly or maybe certain other things. Not always the same pattern of anomalies will recur in each offspring, depending upon the degree of chromosomal imbalance in the gamete and in the resultant embryo, the outcome may differ. But yes, chromosomal anomalies do not follow Mendelian patterns of inheritance. The term Mendelian is used only for monogenic disorders.
Sure. If there are no more questions, then we can just end the session. Thank you, Dr. Pranjana, for the lovely talk. So we can go for the next session now.
Thank you so much for the opportunity. Thank you once again to the organizers.
For the next talk, we have Dr. Ratnapuri, who is a DM Medical Genetics and chairperson of so she's a professor and chairperson, Institute of Medical Genetics and Genomics, Gangaram Hospital. And she has received Dr. I.C. Verma Outstanding Research Award for 2019, Dharamvira Award for Excellence 2010, and a Young Investigators Award in Japan for 2006. So over to you, Dr. Ratnapuri, for the talk on case-based genetics evaluation prior to transplantation, when to send, what panel, and how to interpret.
Thank you very much, Dr. Kanav, and thank you to the organizers for this session. This is a pre-recorded session, and I would request the organizers to play that. I have done this session along with Dr. Kanav Anand, because at least we have the luck and the privilege, I should say, in our hospital to be able to work together as a multidisciplinary team to take forward all these complex situations. Thank you so much. Good morning, colleagues. At the outset, I would like to thank the organizers for this excellent initiative and the privilege of being invited to talk in this very, very important topic of genetics in nephrology. Now, in this series, I have been asked to talk on genetic evaluation prior to transplantation, when to send, what panel, and how to interpret. I'm Dr. Ratnapuri. I'm the genetics head at Sir Gangaram Hospital, and my colleague, Dr. Kanav Anand, who also chairs this session, has helped me put this talk together. So what are the indications of kidney transplantation? If we start from there, we know that all CKDs are not inherited, but when we do inherited, and I'm going to really focus my talk on the inherited chronic kidney disease. So in 20 to 30% of patients, we do get a positive family history, and monogenic disorders account for about 70% in children and about 10 to 15% of all end-stage kidney disease in adults. And there's a host of genes, about 400 to 500, that are associated with inherited kidney disease, which can progress to end-stage renal disease requiring transplantation. If we think of them within a group, we could think of the developmental disorders, which are the CACUT. We could think of ciliopathies that could be cystic and non-cystic, glomerular disorders, and tubular interstitial disorders. So what are the important considerations when we talk about genetic testing? Where should we do it? As per the IPNA guidelines that have come out recently, for steroid-resistant nephrotic syndrome and congenital nephrotic syndrome, we need to test all patients because majority of them have inherited monogenic disorders that can explain the disease phenotype. Other situations where we have a strong family history, very early onset of disease, a syndromic presentation where we have renal involvement along with extrarenal manifestations that would really point towards a genetic basis. And the etiology of a recipient kidney disease is unclear when you've done your host of tests, including the biopsy. And in this situation, when they come to you late, a genetic test may be of benefit. So through a series of cases, I'm going to take you through different scenarios that we have encountered within our hospital. So this was a family history, and essentially, in this generation, that is generation number 3, person number 2 had end-stage kidney disease, and he received a transplant from person number 4. When person number 4 gave the kidney, he was obviously fine. He did not have any overt features or even his kidney function tests were fine. However, a few years later, this person died, and he came to us in very, very late end-stage kidney disease, and a diagnosis of Fabry disease was made, and he passed away early after his consultation with us. Now, while we are looking at this pedigree, you can see that this is more males affected than females, though there is a lady who had renal failure and early onset renal failure. this goes in favor of an X-linked disorder. So wherever there is a family history, whether it's consistent with any pattern of inheritance, it is imperative to first find out what is the cause of the kidney disease, especially when we are taken a donor from within the family. So this case really illustrates that. This person we had called early because he was also at risk. We tested him. He was also Fabry disease, but he had very early onset manifestations of microalbuminuria, and now he's on enzyme replacement therapy. So what is the need here for a live donor risk assessment? Okay, so if we want to understand two things, that what is the risk to the donor of developing kidney disease, hypertension, as well as what are the chances that the recipient will really benefit from the kidney transplant. So we know that in most situations, the outcome for the donor is good. However, when the kidney is taken from within a first-degree relative, there is some increase for that person to develop kidney failure, which is higher than the baseline risk of anyone to develop kidney failure. And it could be direct genetic disorders that are related to a specific disease within the family, or it could be other genetic associations. It's not really very clear that if there is no specific monogenic disorder in the donor, why is there a slight increased risk for developing kidney failure for the donor? Now, what are the guidelines for evaluating the donor? Again, we go back to a family history because there's a lot we can ascertain from the family history. And in specific types of kidney disorders like focal segmental glomerular sclerosis, atypical HUS, Alport, sickle cell trait, and autosomal dominant tubulointerstitial disease, ADPKD, and various mimics of ADPKD, we need to do genetic testing because it really enables appropriate donor selection, and that is very, very relevant. In the second case, we had this 11-year-old boy who was initially identified to have sensory neural hearing loss. At that point in time, he was otherwise well. Over a period of time, he then developed hypertension, hematuria, anasarca, anemia. He had deranged functions. A renal biopsy was done at that time, and he had some mesangial-proliferative pattern of glomerular disease with some amount of tubulointerstitial chronic features. And over the next few years, he went on to develop end-stage kidney disease requiring hemodialysis. Now, this person was then worked up, needed workup to ascertain what was the cause of this phenotype. As you can see here, that there was an extrarenal manifestations of hearing loss. So we may not know all the genetic disorders because there are so many. Some of them are common, some of them are not so common. Now, within this kidney disease as well as hearing loss, we all know and we think of Alport syndrome. But in addition to that, when we do a search, you can see that there are many other entries when we put in deafness and nephritis. And therefore, there are so many more genes, as you can see here, that we need to look for. We want to do it together and not step by step, because when we do it step by step, it becomes very expensive, as we used to do in the days gone by. So now with the advent of enhanced technology, all that you've heard about in the previous talks, and next generation sequencing, we would like to order a test where we are very certain that at least my genes of interest for this specific patient are covered. So we can either do a clinical exome or a whole exome sequencing. You have to liaise with a laboratory where you're sending the sample to ensure that all the phenotypic disorders, including all the genes, because sometimes one disorder is caused by many genes. So therefore, we want to ascertain, for example, Alport only. So we want to ascertain that in that test, all the genes of interest are covered. And whenever we do a genetic test, pre and post-test counseling is very important, which entails explaining to the patient that it's a blood test. Why are we doing the blood test? Because genetic tests are expensive. What is the need for the test? What sort of answer is that going to give the patient, and what benefit is that report to the patient? And in addition to that, There are situations where you may not find anything, or you find some things that you cannot ascertain. So all this goes within pre-test counseling. So for this patient, we did a clinical exome, which covered all the genes that are reported with this phenotype. And we got mutations, 2 variations in a gene, which is COL4A3. COL4A3 is associated with Alport syndrome, the autosomal recessive phenotype of Alport syndrome. Now, do we just take a report at face value? The variants that are identified on the report have to be evaluated based on specific criteria, which are the American College of Medical Genetics criteria, because when we do sequencing, we can get so many different kind of changes, and every change may not be responsible for the disease. So depending upon the nature of the change, as well as the presence or absence of that change in previous published literature, the segregation of the variants in the parents, and Sanger validation of the variant, we then give a definitive diagnosis. No step within all this should be missed. So we know that Alport syndrome so what information do we get out of this? Alport syndrome can be X-linked, it can be autosomal dominant, or it can be autosomal recessive. Okay. And so the genes we look for are different genes that are associated with the disease phenotype. Now, supposing we did the test and we did not find any sort of a change in the report, then we go back to literature, and this is gene reviews. This is a consolidated database of what kind of changes are reported in literature. We see that though 90 to 98%, depending upon the gene that we are looking into, are associated by a specific change in the nucleotide, which can be identified by exome sequencing or NGS. There are some kinds of changes which are deletion duplications that require different methodologies for testing. So a deletion duplication will not be picked up by sequencing. So it is picked up by a quantitative PCR or an MLPA or a microarray that covers these genes. And therefore, all this information and knowledge is important whenever you are ordering a test. Now, I've put in this slide to understand what the various terminologies that come in a report, what they mean. For example, we can see that this is heterozygous and heterozygous, and we say the patient has compound heterozygous variations in the COL4A3 gene. So this is a wild type or a normal gene, as it is with the reference sequence. A heterozygous, and every gene has 2 copies. A heterozygous change is a change in only 1 copy. A homozygous change is a change that is present in both copies, and this change is the same. A compound heterozygous change is a change again that is present in both copies, but they are 2 different changes. Then we talk about segregation of whatever we find in the affected child in the parents, because we know that in an autosomal recessive disorder or in an X-linked disorder, they need to be inherited. There are times, most of the times the variants are in trans. That means they are on 2 different chromosomes, one from the mother and one from the father. However, in some situations, they can be in cis. That means the 2 changes can be on the same chromosome while the second copy of the gene is normal. And for an autosomal recessive disorder, this does not explain the phenotype. And the only way to identify whether the variations are in trans or in cis is by segregating the variants in the parents. So what are the implications of this report that has come in this boy who had kidney failure and hearing loss? It gives us a definitive cause for the phenotype. It tells us about the implications of renal transplant. It will only impact the kidney phenotype, but not the deafness. And later on, they also go on to develop eye changes. So you need additional monitoring for those phenotype, and you need to tell the parents that the kidney transplant is really not going to impact the additional extrarenal phenotypes. The 4th thing that is very, very important is kidney donor selection. And this is really relevant for X-linked disorders. Carriers of autosomal recessive disorders can be donors because there you need 2 changes to cause disease. However, when we have an X-linked phenotype, it is better that a symptomatic woman who has hematuria is not the donor of the kidney. And if there is another male in the family, the test must be done so that you are not transplanting a kidney of another affected person who may manifest later, like in that first family I showed you with Fabry disease, which is also an X-linked disorder. So that really becomes relevant. At times, we cannot find the mutation. It's not as if for a specific genetic test, when we are very sure that yes, this is Alport or this is Fabry, we always get a mutation. There are some situations, 2%, 3%, where we do not find, the mutation in the affected child. In those situations also, at least for Alport syndrome, there are specific guidelines based on the phenotype and the age of the lady as to who should be considered for donating a kidney. Because it's very important to understand you don't want to harm the donor first, and neither do you want to harm the recipient. Coming to the third case. So we know that this common scenario of steroid-resistant nephrotic syndrome is present in about 15% of patients who've got nephrotic syndrome. And about a large percentage of these are of genetic origin and would require kidney transplantations. And we know that in this phenotype, as in the first talk, Dr. Madhulika and Dr. Aditi have already alluded to, that we have mutations that typically impact the podocyte, the slit diaphragm, and the membrane, causing the disease phenotype. Now, look at this family history. We can see that this is not a consanguineous family. They are non-consanguineous. This is an affected boy. The first child had died at 3 months and query nephrotic. No information is available. And very often in India, we know that they throw the papers. Now, in the antenatal period, this child was normal. He had seizures at about 1 to 2 years of months of age, probably hypoglycemia. He had some cortical venal thrombosis and bilateral occipital lobe gliosis. At about 5 years of age, he was diagnosed to have chronic kidney disease and went on to dialysis, and a transplant was planned. So when you're going to do a transplant, you look at all the comorbidities. He had some motor delay. That was really because of the chronic disease, because his cognition was normal. He had associated chance G6PD deficiency, hypothyroidism, and hypertension. So a mutation analysis was done. Now, this was done many years ago, before the easy availability of next generation sequencing, because next generation sequencing has really, really changed how we manage the patients at low costs. Now, these are all very big genes, NPHS1, NPHS2, WT1. So we used to find laboratories where research is going on, speak with them, talk to them about the patient, and then send the sample. And depending what their protocol was, what their research was, they would do different kinds of testing. Now, for this patient, they did direct Sanger sequencing, which is testing the gene nucleotide by nucleotide, one at a time. NPHS1, NPHS2, and the WT1 genes, which are the common genes that are associated with congenital nephrotic syndrome or steroid-resistant nephrotic syndrome. Now, we know that this is an autosomal recessive disorder, and 2 variants were identified in the NPHS1 gene. So this was at the cDNA. This was a change of the nucleotide T to C, which causes a change at the protein level of the amino acid. And always we need to look at this, because there are so many kinds of sequences. There are so many kinds of proteins that are present in the body. These proteins are of different lengths, and therefore this numbering changes depending upon the length of the protein. We all use a specific reference sequence world over, so that we all know that we are referring to that specific reference sequence. So in your reports or whenever you are communicating, this reference sequence must go through. Now, this is a missense variant. That means there is just a change in an amino acid because of the change in the nucleotide in the first exon of the NPHS1 gene. Now, we know that the NPHS1 gene causes the disease phenotype because of a loss of function. So this report, this variant has never been reported. It is not a loss of function variant. So you become alert. Is this responsible for the disease phenotype? So you have various ways where you can go in, look at the various normative data. Is it reported in any normal individuals? Is it reported previously, either in published literature or in different databases? Even if it is reported, like here, this was reported in 2017 in a specific database, but there was no functional data for evaluation. And we know now, as we are getting more and more information about all this, and as technology is improving, lots of things that were initially considered to cause disease phenotype are now benign variants. So you have to keep all that in mind when you're evaluating these variants. And therefore, this remains a variant of unknown significance. Compared to the previous variant, that was a pathogenic and a likely pathogenic variant because of the impact on the protein and the fact that it had been previously reported in a patient where functional studies had been done, which remains the gold standard. Then we did further things. We correlated it with the disease phenotype, and we segregated the variants in the parents. And when we do that, we add on to the ACMG criteria, and there was a change in classification from variant of unknown significance to pathogenic or likely pathogenic. So predominantly, this was a change to likely pathogenic. So remember, just what comes on that report may not give you adequate information. Very often you have to work on those variants beyond what is given in the report to decide whether it can be consistent with your patient's disease phenotype. Now, it's a recessive disorder, so you need a second variant. The second variant here was again a change in a nucleotide, but this was terminating the protein translation. And remember, initially I told you loss of function is a mechanism. And because the protein synthesis is being terminated, it is not working. And so it is consistent with a loss of function mechanism. And then we also look at different databases. We look at different submissions. And you can see that although there was no functional evidence for this variation, it had been submitted 18 times in literature. So now I'm fairly certain, once I've segregated the variant, that this is a pathogenic variant. And my patient who has steroid-resistant nephrotic syndrome is because of these two variations in the NPHS gene. Though this remains a variant of unknown significance, and I will keep it like that, still, because of all the workup that has happened, we will consider it causative of the phenotype. And this patient, because he has two different mutations or variations, as we call them now, is compound heterozygous for the NPHS1 gene mutation. So what is the utility of this report? We always knew that the patient had steroid-resistant nephrotic syndrome. What does this report add? It gives you a definitive etiology because there are so many genes that can cause disease phenotype. It can be autosomal dominant, it can be X-linked, it can be autosomal recessive. And we know that this is a severe phenotype. And then for transplantation, because it's a recessive disorder, we can use a living related donor for NPHS1. There is no evidence of poorer graft outcome or recurrence compared to a specific NPHS2 mutation, where we know that as they grow, they can develop adult onset nephrotic syndrome. So these are so many things that we have to look into and consider before taking a patient up for transplantation and doing his genetic workup. So now the issue is that what is the anticipated recurrence risk post-transplant? And that's a question that every patient is going to ask the nephrologist. So there again, you need information that is the disorder genetic versus non-genetic. And we told you that only a small percentage of them are genetic. The rest of them are non-genetic. If we have a genetic etiology and you have transplanted the appropriate kidney, the risk of recurrence is negligible. It's baseline. So there are different reports up to 5%, 7%. However, if it is non-genetic, there are circulating proteins in the body which can cause a very high risk of recurrence of up to 50 to 70%. So I'm not going to talk about the other factors which you all are experts of, but really the genetic impact of this in steroid-resistant nephrotic syndrome is very, very essential to counsel these. However, there are some specific, very, very severe mutations, especially NPHS1 related disorders were first reported in the Finnish community. They have very specific mutations. So if you have a patient from that community, you don't sequence the full gene. You just look at that specific mutation. But they will have recurrence of proteinuria because they develop antibodies against the foreign protein that comes in the transplanted kidney. So that is the information and the relevance of having a genetic test for these patients. So what is the kind of workup we are going to do for congenital nephrotic syndrome? It starts from examination because you can look for extrarenal manifestations. The preferred time of genetic diagnosis is at first point of contact prior to the renal biopsy. You wouldn't want to do a biopsy if you get a genetic report, and prior to considering transplantation, because genetic tests take time to return. You don't know what additional workup is required after getting the initial report. And all this has to be communicated to the patients. The patients feel that if they've done one test, which is fairly expensive, they will get all the answers that they're looking for. And we know that in 60% of the times, this is not so. You would need to do additional workup for those variations that are identified on the NGS. Or if there are no variations identified on the NGS and you're very, very confident about your phenotype, you need to go back and relook at the data to see if something has been missed in the reporting. So what test do we do? It depends upon the accessibility and availability. And if we talk about India, these tests are accessible and they are available to us. We want to look at multiple genes together in a situation of steroid-resistant nephrotic syndrome or even the other phenotypes, and we can do a next-generation sequencing, which is just the technology. Within next-generation sequencing, which is a very high-throughput sort of a test, it looks at many genes very rapidly. We can do a clinical exome here, where just limited genes, about 4,000 to 5,000 genes that are known to be associated with disease phenotypes are present. Or we can do a whole exome sequencing where all 20,000 genes are represented in the panel. But I think more important than what test you order, you need to communicate with the lab to say, well, this is what I'm looking for. Please make sure that all the genes of interest for this phenotype are covered within whatever test is performed. There are challenges again of NGS, and I think the biggest challenge is a variation of unknown interest, variation of unknown significance, where we don't know with the current knowledge, is that variant associated and causative of the disease phenotype, or is it just a variation that will not cause any disease phenotype? We could get this in the specific genes related to the phenotype, or at times we ask for additional workup, and we can also get it in unrelated genes. There are some things that are mixed on NGS, and these are complex rearrangements. These are sort of complex changes in the genome, where these are large changes which are turned around, which are missing, which are duplicated. And for these, we have to order different kinds of tests. And I think last but not the least is, sometimes in these panels, you can have suboptimal coverage of the genes of interest. So you may think that you have not identified a genetic basis for your patient, but it could be that a variation is missed because a specific exon of that gene is not covered. So there has to be enrichment of the target genes, because remember, you are doing large number of genes. So when you're doing anything very rapid and very high throughput, there is a chance of missing some things. So it's very, very important to liaise with the lab to make sure that all your genes of interest are well covered, and not just as a percentage that comes on the report, but as the exons that are seen in the data. Then we talk about karyotyping. The only role of karyotyping in nephrotic syndrome is where there is ambiguous genitalia, or you've got a variation in the WT1 gene. The sample you can use is an EDTA sample. It's a blood sample. Sometimes, because of the excessive edema and all, you may not get a good sample. In that case, you can use a buccal swab. And if a newborn screening has been done for your patient, we can even take out DNA if the newborn screening filter paper has been saved. We don't get very good outcomes there, because most commercial labs say that they have thrown the filter paper. But yes, that is always an option. And In congenital nephrotic syndrome, the role of genetic testing is only in situations of NPHS2 that I alluded to in the previous slide, and also in WT1 mutations. If it is inherited by any chance, then that person should not serve as a kidney donor. Okay, now we come to this next slide, where this was a girl who was 14 years old. She came in renal failure at that age. However, she had been following up previously. She had antenatal onset, some developmental abnormality of the kidney. There was growth failure. The ultrasound had shown some cysts in the parenchyma, and now they were involving both kidneys. So a clinical diagnosis, because there were cysts, of autosomal dominant polycystic kidney had been entertained, and there was no family history, as you can see in the pedigree. And the father was going to donate the kidney. So as is the, what is done in my hospital is, we do a genetic workup. First, you go and look at, well, what are the situations where we have, say now later we identified that this lady had also diabetes. We look at what are the other genes that need to be covered. Okay, so you go into literature, you have to do this exercise so that you make sure that when you're writing the phenotype for the test, you have to write a detailed history using all the phenotype that is there in your probank. If you're sketchy in your information, clinical information that you provide to the laboratory, the report will also come back to be sketchy. So we got a very, very unexpected result in this case. It was not the ADPKD1 or PKD2 gene. It was an HNF1B gene. It was a change in that gene. And this was a significant change, a splice site change that was likely pathogenic. And this disorder is associated with renal cysts that were there and diabetes syndrome. And now since we had never heard of this disorder, and now as we've started using NGS more and more, and initially we had thought that for dysplastic kidneys that are identified in the antenatal period, we really don't need to do any testing. But now with increasing information, we realize that you can have phenotypes like this within the CACUT group that require genetic testing. Now, this disorder is autosomal dominant. We know that there was no history in the family, but now we need to go back and ask the parents, do you have any diabetes? Because some things like that, which are so common in the general population, are probably not talked about or discussed or informed voluntarily. Now, there was no renal phenotype, and the parents were then evaluated for for this gene variant. It was de novo, or it was not present in the parents and it happened in the baby by chance. But when we are counseling this family, we know that even after the kidney transplant, we have to monitor for diabetes. Some of them can have genital tract abnormalities, so that has to be evaluated for. In the next case, this was again a non-consanguineous family, though there was a history of cancer, there was no renal phenotype. And at 2.5 months, there was some sort of seizure. At that time, there was hypertension, cardiac hypertrophy because of the hypertension, deranged renal function tests, and the bilateral kidneys and ultrasound that was done. Actually, she only came to medical attention because of the seizure. She came into hospital, and in hospital, she was detected to have hypertension. And then hypertension in such a small baby, the entire workup is done. And the kidneys were normal size, but they had poor corticomedullary differentiation. So infections were evaluated for, there was nothing like that. A biopsy was done and there was diffuse mesangial sclerosis. And then on doing the genetic test, a heterozygous variant in the WT1 gene was identified. It was present in exon 8. This was a missense variant and it was a novel variant. So again, we have to work up to see that can this variant be associated with the disease phenotype of this young girl. So you go back into literature, you see, well, yes, most of the variants, 90% of the variants are present in the exon 8 and 9. So this is the common exon that is present. There are specific sites in the protein and the impact of the variant on the protein that cause the disease phenotype. And this variant was also present in the DNA binding residues. So all this information has to be gathered before you can confirm. Then because it was WT1, you have to do additional workup. Phenotypically, the child was a female. When we did the karyotype, it was 46XY. So we had a male to female complete gonadal dysgenesis because inside there were Mullerian structures. However, the gonads could not be seen. And we know that in this, we have to also monitor for Wilms tumor because they have a high chance of developing Wilms tumor and gonadoblastoma. So now just this information changed the entire protocol of management of this child. The mother was to be the donor. So the WT1 variant was checked in the mother because she may not, in all autosomal dominant disorders, it's important to know that the phenotype may not be what is there in the child. There can be extensive phenotypic heterogeneity. So you don't do a clinical exome or a whole exome in the parent. You just look for this one variant in the mother by Sanger sequencing. So she did not have the variant. So the transplant was planned. At the time of transplant, a nephrectomy and a gonadectomy was done because this is one of the few indications where this is done for because of the kind of variant that is present and the gene that is involved, because there is a risk of Wilms tumor and a small risk of gonadoblastoma. So you can see that the entire protocol of management in this case has changed. So these WT1 disorders are present with steroid-resistant nephrotic syndrome. They have gonadal dysgenesis. Additional phenotypes include early onset bilateral Wilms tumor, gonadoblastoma, and they could have additional developmental abnormalities of the genitourinary tract. So all this has to be screened for before just going in for a transplant. You can have some situations where there are additional anomalies, especially related to the eye, and that is because of large gene deletions. And these large gene deletions are picked up by the other methods that I talked to you about, including MLPA or a microarray where these genes are covered, or a qPCR, a quantitative PCR. They would not be picked up by an NGS, at least in the current scenario. It's not the standard of care. So we've already discussed about the implications of WT1 in the proband, and we just take it forward in an organized manner. So you know that you would want to do surveillance and evaluation in the proband for the extrarenal manifestations. Molecular genetic testing would be required for the parents because in most situations, it could be an apparently new variant that is present in the child. However, some parents can be mosaics, so they may not have the typical phenotype of WT1 as we know of it. And we could also have other situations which are actually not so common because we don't ask, when we ask them directly, we can, understand that they could be ART. So there is a change in the egg or the sperm, or it could be an adopted child, or they may be alternative paternity. And the last one, the paternity issue, we may not talk to for the family, but we have to keep that in mind when things are not fitting the bill. Supposing you have two children with WT1 related phenotype, then you would think as to how this variant has come. We also would need to evaluate asymptomatic siblings because it's a dominant disorder, and I told you there is extensive variation of expression because of incomplete penetrant karyotype of the proband, and then screen the potential donor for the familial mutation. So those are specific disorders, the genes that are associated with them, and their implications for transplantation. Another very important aspect of genetic testing is pharmacogenomics. Various immune suppressants that are used, what is the dose of the suppressant to be done, and this is something that we routinely do in my hospital for this CYP3A5, which is the one that is predominantly associated with the TAC levels. We look at these 3-4 polymorphisms, and based on this, the doctor then decides, the clinician then decides what is the dose that needs to be given, or there are other sort of genes that are also looked at. So what is the most appropriate immunosuppressant to be given and at what dose to be given, rather than waiting to see that the child is not responding to one and then changing it, because you may miss the boat there, or it may cause a lot of side effects because of Supposing there is a slow metabolizer and you give the normal dose, it can cause a lot of adverse events, because in slow metabolizers who have this phenotype and this allele, you require a much lower dose to reach the therapeutic level. So there is a lot of scope for pharmacogenomics, including that in renal transplantation. So before I conclude, I think I'll just put together what I've talked about. You have a patient with end-stage kidney disease for whom a transplant is planned. We start not directly with the test, but we start with details of the family history, a detailed evaluation of the child to look for extrarenal manifestations and look for infections, drug toxicity, the other markers, an ultrasound. And what I'm going to really focus on is the genetic testing. All children with steroid-resistant nephrotic syndrome, or where there is a familial cases, there's a family history, we would want to do genetic testing, especially where a kidney transplant is planned, and you could do that before doing the invasive kidney biopsy, because the genetic testing is done on a blood sample. These are genetic tests, so you need to take an informed consent for the genetic test. You have to do pre-test counseling, alluding to the points that I have discussed previously in my talk. What are the various genetic testing modalities? They are microarray for large DELs and DOOPs or MLPA. Make sure that the genes of interest are covered. Or when we want to look at point changes or small DELs or splice site changes, we do a clinical exome that looks at the about 4,000 to 5,000 genes that are known to be associated with disease phenotype. We do whole exome sequencing, that is 20,000 genes that are present in our genome. And we don't know the function of all the genes, but the advantage of doing this is that maybe you'll find a new gene if you continue to work up your patient. But the disadvantage is that in clinical exome, like in a clinical exome, the coverage may be a little limited in a whole exome. In clinical exome, because you're doing fewer things, the coverage is much better and greater depth. Then the interpretation of this genetic test requires great expertise, and the geneticists and the nephrologists need to work together. So it is a lot of what we call multidisciplinary care now. The variations or the reports that you get could be, like I said, pathogenic, likely pathogenic, or a variant of unknown significance. We could be looking at new genes. Sometimes you can get reports where they've given you variations in additional genes and you need to counsel the families for that. We need to discuss with the patient that all genetic tests take time. That we should never hurry up for a genetic test. You need a specific turnaround time. Even once the report comes, you need to evaluate the report, and therefore you should have those sort of timelines. So whenever we are ordering a test in this clinical scenario, you must understand and you must share with the laboratory what is the indication for the genetic testing, just like you do an MRI or any investigation, histopathology investigation. Unless you give the clinical phenotype, you won't get a good result. You have to understand which technology to use, because one test does not fit all. Genetic tests can be performed even after end-stage kidney disease has developed. You need good pre- and post-test counseling. You need to talk to the parent about these VUSs that are identified where you're uncertain about the clinical explanation. And a negative result does not give you guarantee that you've excluded a genetic disorder. Maybe the gene has not been identified. And so this is the era of precision medicine, and really doing genetic testing prior to transplantation aligns with the concept of precision medicine. And because there is a great in-depth knowledge that is required in this scenario, there has to be a multidisciplinary team management. Thank you very much.
We request the chairpersons to take any questions. Dr. Kanav Anand and Dr. Joyita Bharati.
Ma'am, till the chairpersons come, can I ask you a question? Are you?
Yes, sure.
Yeah, thank you, ma'am. Excellent presentation. So you have listed in the indications for genetic testing CKD-U, and very rightly so. So I just wanted to know, in this case of CKD-U, do you have any data or any personal experience? What sort of genes are you getting? I mean, any data is it available so far on the genomics of CKD-U?
I think the data which Dr. Aditi had showed, we do have some data, but nothing that is collated sort of a thing. That's probably the first multidisciplinary effort that has been done to bring together Indian data. Otherwise, there's literature which is available from all over the world.
If you allow, I have
answer this if you have some data. Yeah. Aditi, do you know about this? She there?
I don't think she's.
Continue.
She had talked about that DBT project, which they had published, I read, in Indian Pediatrics in 2021. So I think we could all allude to that publication. So this is a multidisciplinary DBT project where they were doing
If you allow me, can I ask one question? Because just for my curiosity, Madam, it was an excellent talk and I thoroughly enjoyed the whole of it. You mentioned about one girl who had a renal cyst and diabetes syndrome. And then you said that the father was going to be the donor. Do you remember do you remember the genetics of the father and who ended up being the donor?
So he did not harbor the variant. So for some of these variants, they can be inherited from the parents, and some of them happen de novo. So luckily for this family, it was de novo. In fact, we had another family where we identified actually prenatally. And the reason where we did the genetic testing was it was an IVF pregnancy. And in the IVF pregnancy, they had put in two embryos. And both embryos ended up having dysplastic kidneys. So it was very odd, you don't find things like that. And when we did the test, we found this gene. And when we went back into the family history, the father of these fetuses and his father only had diabetes. We were able to segregate the variant in them, but they did not have any renal manifestations. So just to show that there can be so much of phenotypic heterogeneity, and the only way to really for sure is certain is by doing the genetic testing.
So regarding the patient who turned out with cystic kidney disease with the diabetes, so I just like to tell this child was actually referred to me as having a multicystic dysplastic kidney in the background, and now the kidneys are shrunken and this child is due for a transplant. So the good part of doing the genetics was at least we came to know it's not multicystic dysplastic kidney. It was actually the genetic variant. And this patient, actually, when we gave the tacrolimus and the steroid, this child actually went into developing diabetes, which was not there initially. So at least we knew that these things are bound in the future phenotypically. So at least we could take care of it right from day one. And I'd like to admit that it's a boon for the physician to have a robust genetic department in our hospital, because a lot of places where we get stuck, we do not have answers. So there, the Dr. Ratnapuri and our department does pitch in. So like as it happened in the Alport syndrome child. So it was actually again being managed as a nephrotic syndrome. And during the phase, he had that infection and was given amikacin. So the pediatric nephrologist there, where the child was being managed, thought that this child was actually having the hearing loss because of the amikacin. And finally, when the child came to us as CKD on dialysis, when we went ahead and planning for a transplant, we get the genetic analysis and it turns out to be an Alport syndrome rather than just amikacin-based loss of hearing. So very well said, ma'am, that genetics does help in one coming to a diagnosis that what is the reason for this CKD. Secondly, it helps us not only in screening for the child, but also for the parents, that who will be the most apt donor, because as the rule goes, the donor should not get compromised at any point. So any other questions, any queries?
I just wanted to add one point. Since Dr. Manisha had asked previously, I've just posted it in the chat box. One of the Indian variant databases which is available is the Indigenomes. it's an open access database. It's publicly available, and you can actually put your variant in that and check as well. So at least it is representative of our Indian population. They're not a very exhaustive database, and they're, of course, adding on to it and building it up further. Thank you.
Pradnya, I contacted Aditi. She was not able to hear. So now she can speak on that question, the etiology of unknown CKD. Aditi, can you hear now?
Yes, ma'am.
Okay, this
Ma'am,
the question
yeah.
was that if you do WES on unknown CKDs, what are the common etiologies you find and probably the yield?
Yeah.
Is
Yeah. So
there's any Indian database? I think that's
Indian
what
data, basically Indian data, yeah.
Indian database.
ma'am, there is no database as such, and definitely not enough data has been collected on patients in whom we are doing for unknown CKD. So we only, each of our units would probably have some small databases, which probably we could consider about publishing together. But overall, when we do for unknown CKD, usually, it is not clearly unknown. When you do it in absolutely no clue situation, then probably the yield will be really low. Usually you have some clue or the other, something like polyuria, polydipsia in the background, which makes you suggest a diagnosis of nephronophthisis, because, the childhood CKDs that progress in the second decade of life and for which you'll be doing genetic testing for prior to transplantation would usually be either nephronophthisis or cystic kidney diseases, primarily, or FSGS, which has been missed, or Alport syndrome, which has been missed. So these would be the entities that would be coming up. We have had definitely, though it is not classically unknown CKD in the context that we would find these findings, because you would almost always have a clue to the diagnosis. What we finally end up as calling as unknown CKD is probably a sequelae of Kakut, for which not a precise pathology has been determined, like maybe, reflux that abated and you just have small hypodysplastic kidneys. Therein, the yield of genetic diagnosis is definitely low. So we have had NPHP contiguous deletions. We have had MYH9 in a couple of cases. We have had FSGS genes or COL4A5 in situations. But then when you go back and look at the urinalysis or historically, you would find some clues that lead to that diagnosis as well.
Possibly they are missed because we don't probably recognize everything. And over a period of time, as we are able to correlate more genetics with the phenotype, especially for Kakut, I feel.
Yes.
I think this is a domain that requires more, even whole results. So probably we need more gene discovery or more understanding of the pathways.
Yeah. And just another point I would like to add here, that if you are suspecting a genetic etiology very strongly, and if your whole exome sequence has not revealed any variant, there's always a possibility that the variant may be a deep intronic variant, or it could be one of those, exonic deletion or duplication, which may have been missed in the whole exome. So if you really are very strongly considering a genetic etiology and the WES comes negative, you can consider going ahead with whole genome sequencing in a few cases as appropriate.
Yeah, that's right. Although we haven't had occasion to do that, but yes, I agree.
And in some cases also, I found that some platforms where you're very sure of a clinical diagnosis, it's worthwhile to go back and look at the raw data, because at times there are specific exons in a gene that are not covered.
Yes.
And so that would need to be covered by either Sanger sequencing or another platform.
Yeah.
So I think before we go on for, additional things, so that's why the phenotype, I always feel, becomes very relevant. Of course, in absolutely advanced cases, we may not have that opportunity, because that still forms a small percentage. So I think it's very relevant to do that.
Ma'am, Dr. Ratna, ma'am, like your last point, what you said, looking at the raw data. So as of now, we are having the printed reports with us, but we are not asking the patients to get a soft copy of the whole thing. So do we need to do that if we want to go back and look at the genes later on, the whole thing later on, or it's automatically done and laboratories share their data?
Most laboratories, so it depends if you're working with a genetic unit. All the genetic unit get the raw data of the test that they order. Not that we look at the raw data of every patient. It's not humanly possible. But say, supposing I have a disease and I know that it is genetic, I know that there are 2 or 3 people affected in the family, but I don't find anything, then in that case, as an individual case, I would want to go back and look at the raw data. And it's not, the patient doesn't have the raw data. So it's transferred on cloud. You need specific computers to download that data, to maintain that data. There are so many issues that are related to data privacy, etc. So supposing another doctor has ordered the test and I feel, no, as a geneticist, I must get the raw data and look into that data for certain things that there may be gaps in that data. I take written permission either from the patient, or I get in touch with the old doctor and say, well, I think it's worthwhile to look into this. So please give me permission to access the data. So I'm not sure whether as an individual nephrologist, it would be of any benefit for you, because there you would need bioinformatic help. You would need a geneticist. You would need those Linux computers, etc. to do that. You need a specific server to get the data. But what you can do is, if you're not working with a specific genetic unit, either get in touch with somebody who's close by to where you're working, or get back to the lab and ask them that I'm strongly suspecting that my patient has, let's say, very easily Alport syndrome. So just make sure that all the exons and the genes are covered related to Alport syndrome.
What happens is all of us do not have access to the genetic lab inside our state government hospital setups. We are getting the genetic analysis done, for example, in Hyderabad in CDFD with Dr. Ashwin Dalal, and he is also outsourcing it to MedGenome. So MedGenome has that data. So what I meant was, like, obviously we are just getting the printed report, but MedGenome, I mean, the data would be stored for some number of years, and if we want to go back and look, can that be done?
You can, and you can always take Dr. Ashwin's help to take that forward. The data would be there with MedGenome.
Okay, they don't delete it, they keep it forever. Any lab is supposed to keep it forever, right? We can.
I don't know what the forever is, but yes, we are able to source the data even which is done previously.
I think Ratna, they would keep the data as their own internal database also.
Yeah.
So I have done it some number of times. We have asked the MedGenome people to get back with the raw data. They would charge 5,000 or something extra, and then they would get back within a week or so. Although we don't interpret it, we ask the geneticist to do it for us.
That's the way it's usually done.
Yeah, depends. And just one more point I'd like to add here. So in fact, apart from what Ratna ma'am already mentioned about reanalysis of the existing data to look for variants in your known genes, sometimes, especially for genetically heterogeneous conditions like SRNS and all that, you may have new monogenic causes identified over time. So in fact, it has recently happened that we had siblings who had a picture of SRNS who were evaluated in 2018. And at that point of time, whole exome sequencing was done for them, and the lab had given a negative report. And 3 years down the line, or rather 4 years down the line, when the same whole exome data was reanalyzed, we found that there was a homozygous pathogenic or a likely pathogenic variant in a gene, which was a newly discovered gene as a monogenic cause for SRNS. It was like first reported in only around 2020 as a new monogenic cause of SRNS. So at the time of the original reporting in 2018, that gene was not really identified to be a cause of SRNS. But now 4 years hence on reanalysis, now that we know that this is one of the recently identified causes, we picked up the variant on reanalysis. So review of data is another important thing that actually labs are supposed to do on a 6 monthly to 1 year basis, but may not always be practically possible, again, given the large numbers.
Yeah, and Pragna, ideally they should actually inform the physician who had got that test done if the variant has been reclassified, like in your case. But then I mean, I don't think in India they are doing that, but I think outside labs have that kind of mandate that if the status changes, they communicate to the physician about the status.
Yes.
I think ended. We have ahead of time, and we could end the session. Dr. Kanaf, if you have to make some comment.
Sure. So basically, it was lovely having all the speakers giving such lovely deliberations and telling all the physicians when to do genetic testing and what are the implications of it.
So I think we can end the session here.
Thank you very much.
Yeah. Thank you. Thank you all the
Thank you. Thanks
speakers
all.
as well
Thank
as
you
my
very much.
co-chairperson.
Thank you.
Thank you.
so much.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank all the
Bye.
speakers, all eminent personalities in the field of medical genetics India, for an excellent presentation. All nephrologists have benefited a lot. We have learned a lot and we'll try to implement in our day-to-day practice. We could not have asked for a better start to our conference.